So before we officially begin, we started off the session, for us, if I'm right, on 7th of July, and today we are at 6th of September. So exactly 2 months since then. And the aim was to ensure that there won't be any financial constraints or any financial or monetary interests that will be involved in the conduction of GynoScope. Of course, there's a lot to teach in OBGY. And if I'm going to talk about teaching theory, then it is going to be virtually impossible to do it. Hence, we decided that only the practical sessions would be taken. Usme bhi, we decided that we won't be doing the table vivas and things that are already there in the books. We'll be focusing on truly the true practical part, the true practical side of things. And we hope that we have been able to do justice to your time and to your time over the last 12 weeks, 12, 13 weeks. So as we come to the end of this entire marathon series, we hope that you all were able to benefit from these sessions. There have been a lot of queries. Two, three of the commonest ones were regarding gynae cases, which we are going to be doing today, and the other was regarding the recordings. Now, the thing is, given that it was not a monetary thing, and we may be conducting it next year again, possibly, I'm not sure, it may be a different tutor, different faculty next year. But given that we have not yet taken a decision on whether the recordings are going to be provided or not, we do understand the duties and everything that you all have stated, and it's a genuine issue. We do understand that, but we are yet to take a call on that. The call shall be, a meeting shall be convened over the forthcoming week, and we'll let you all know about it. So I hope we can start now. And this session is going to go on for the next 2 hours. A few ground rules. Now, I have made 4 notebooks for the 4 teams, and those 4 teams are going to be at one point of time. A single team is going to go ahead and will be answering 4 cases. I've randomly allotted 4 cases to each team, so a total of 16. The cases have been taken from 10 different colleges across India, and I had all the cases, all the gynae cards of several colleges, so I made sure that there is an equal distribution, and I've also ensured that each team, the teams that are there, they are not going to get the cases that are there in the gynae cards of their colleges to ensure parity. Of course, there has been a blinded process. We have not given any of the cases to any of the participants, so it is going to be them seeing that case for the first time when I present it. Roughly, I'll be giving half an hour per team, and in that half an hour, they have to somehow manage answering the four cases. If they believe that they would want some time to think on one case, they can skip to the next one. The marks are going to be given on a cumulative basis for all the 4 cases together. So let us begin this session. Porus, would you want to say something about how this event has
Um,
been? And
so the thing is, Dia, I would like to ask Dia to start with a formal introduction from our end before we begin the actual case cards. So over to you, Dia.
Good evening, everyone. It gives me great pleasure to welcome you all to the finale of GynoScope 2025, the Tiebreaker Round, a collaborative academic initiative brought to you by Dr. Aditya Nimbkar and the academic team of SIMSOG. GynoScope was envisioned as a platform where young medical minds could come together to learn, challenge themselves, and grow in the field of obstetrics and gynecology. Over the past few sessions, we've explored a wide range of clinically relevant case discussions, quizzes, and interactive learning formats that have engaged students from across the country. And the numbers speak for themselves. Over 1,700 participants, over 125 colleges, 24 presenters, 12 topics, 8 weeks, and one shared objective: academic growth through collaboration. As we come to the close of this wonderful journey, these numbers are proof that Gynoscope has been a raging success. Looking ahead, SIMSOG is also exploring the idea of a PG series of gynecology case presentations. If you and a colleague would like to present as a pair, we would love to hear from you. Just drop an email at the official email ID, which I will be putting in the chat box. But before that, tonight we have a very special finale. After an exciting run, we have arrived at a unique juncture, a four-way tie. And so our finalists are back to back to face the gynecology case card in this tiebreaker round. We are delighted to welcome our four teams: Vineet, Chandak, and Sumedh Akarte, Apoorva, Malwade, and Uditi Joshi, Mohak, Agarwal, and Srilekha, Anand, Darshan, Bhandari, and Mohit, Patil. We look forward to a session filled with clinical reasoning, thoughtful discussion, and academic spirit.
Thank you so much, Dia, for this wonderful introduction. As the executive director of SIMSOG, I'm very happy that we were able to organize this, especially at a free, like as a free event for everybody, so that we can learn with the expert guidance of Dr. Aditya Nimbkar. And it has been a wonderful time with peer-based learning, with everybody of you sharing notes and like basically growing hand in hand. So it is kind of positively overwhelming that it has been 2 months since we started, but all kudos and all props to Aditya sir, to the entire academic team of SIMSOG, the all the presenters throughout the 12 sessions, and also importantly, you audience. Thank you so much for that. We hope that you all learn a lot in today's gynecology case card series. Now, over to you, Dr. Aditya Nilkar.
Okay. So what I'll be doing is, first of all, by the way, just excuse me, there's a Ganpati Visarjan that is actually going outside my house, and there's a pond where the Visarjan is done just next to my the place where I stay. So please excuse the firecrackers and the music that may intervene. I hope that my voice is still clear enough for you all. I hope it is clear enough and it is not, the background might be a little distracting enough, but I hope my voice is clearer than that. Apart from that, so first of all, I hope everyone's mic is working. Everyone, I mean the team's mic. And which team would want to come ahead first? Vineet, Srilekha, Darshan, which team? Just let me know first quickly so that I can share my screen. If not, I'll just randomly be choosing up a team to do it. Vineet, Sumedh, are you all ready? Should we go ahead with your team first? Vineet,
Okay, sir.
Sumedh. Okay, great.
Okay, sir.
Just a moment. Okay, is my screen, the shared screen, visible to you?
Yes, sir.
The OneNote is visible. Can you read the OneNote and the slide?
Sir, we have firecrackers running in the background. Can you skip to the next team and we can take over in 20 minutes or something?
Okay, fine. Apoorva, Uditi, are you ready? Apurva, Uditi?
Yes, sir. We also have background noise, but I think that.
Unfortunately, we can do nothing about it. So do I have it, but then we'll just have to proceed with that. So Apurva, Uditi, should we begin with you?
Yes, sir. We can begin.
Okay, fine. So Apurva, Uditi, beginning. It's 9:15 now. We'll be doing this for the next half an hour. Your cases first. Should we begin then? Hello.
Yes, sir. Yes, sir.
Okay, fine. So the first case, I'll be reading it out quickly, and you will be talking about the management part about it and your differentials. Remember, at your level, I would want to know the differential because we are not giving you access to all the ultrasound features and everything. So differentials are more important than your final diagnosis. Always remember that for all your exams in your final MBBS. So, beginning. And it's okay to exceed the time by a few minutes. That's fine. But 30 minutes is the approximate time that I will be giving you for all the four cases. So, it's a 45-year-old female who's para 2 living 2. Tubal ligation was done. Sterilization was done. She came with heavy, prolonged menstrual bleeding, dysmenorrhea, passage of clots since 6 months. Her menstrual history is she has had her last menstrual period 7 days back, 7 to 8 day cycles with 25 to 30 day intervals, regular, heavy flow, painful. On examination, she does have pallor. Abdominal examination shows that there's a 20 weeks mass that is arising from the pelvis and it is firm in consistency. On speculum examination, I can see that the cervix and vagina is healthy and there is active bleeding. On per vaginal examination, I can feel that the uterus is of 20 week size and the bilateral fornices are free. So, what are your differentials and how would you manage?
Sir, the as the case is case of perimenopausal female with heavy prolonged menstrual bleeding, dysmenorrhea and clots, which is and regular cycles and mass arising from pelvis. We would like to give the differentials of uterine fibroid or leiomyoma. Then another differential could be adenomyosis. Another differential could be a
Endometrial hyperplasia, endometrial carcinoma,
or another could be a ovarian tumor,
like granulosa cell tumor.
Okay. So, your first differential was uterine fibroid. Could you tell me why is that your first differential and why are the other differentials more unlikely than that? What are the things that you see in this case?
Sir, the uterus, we can feel the uterus up to 20 weeks. The fornices are free. Along with the other symptoms of menorrhagia,
So, what does your bilateral fornices free rule out?
Carcinoma, like invasion into the parametrium.
Okay. Something else as well?
it
Ovarian tumor.
Very good. It rules out your adnexal masses primarily, and your malignancy is going to come much later. Your primary thing that is being ruled out by furnaces free is going to be an adnexal mass. Okay. And of course, as you mentioned, that the parametrium would have been taken up if there would have been invasion carcinoma. Okay, great. What else makes you think that this is fibroid? Anything on the abdominal thing?
abdominal. Because it's a 20 weeks mass which is palpable from the pelvis. If it was adenomyosis, would not be so large.
Hmm.
It would be
Correct. And
around 12.
anything else? Anything else? One more thing in
and
your
it's
abdomen.
and it's firm.
Very good. So it's a firm thing. Okay, great. Could you tell me what is the cause of dysmenorrhea and heavy menstrual bleeding in a patient with fibroids?
Or heavy menstrual bleeding is because the fibroid, if it's like a submucosal or mucosal fibroid, it increases the surface area, which causes increased, like, so endometrial surface, and also there's increased the estrogen causes increased vascularity, so that causes heavy menstrual bleeding.
Very good. So the thing is actually whenever you have a fibroid that is touching upon the endometrium or is a submucosal fibroid, so there is of course an increased vascularity to the periphery or to the capsule of the fibroid. That is one thing. And secondly, the endometrium, which is present on the part where the fibroid is present, is going to be very fragile. The blood vessels and the endometrium, they both are going to be very fragile, and that is going to be the reason why the patient bleeds a lot. Whereas, what is the reason she will have dysmenorrhea?
So because the fibroid can be pretty big and it can cause pelvic pressure and impinge upon the surrounding adnexa.
Okay, yes, correct. But then that would lead to chronic pelvic pain. Why dysmenorrhea in particular?
Sir, because when the menstruation happens, the uterus contracts and it can cause interference with the contraction, so maybe that causes.
Correct. Excellent answer. That's a great answer. So basically, during menstruation, your prostaglandins that are released from your corpus luteum, they are going to cause uterine contractions, which is actually what gives females the cramping pain. But whenever there is a mass that is present, it leads to distorted kind of a pain, a dysfunctional pain, which is going to be much more than your usual cramps. That is the reason they will have dysmenorrhea. One more thing. Do you usually get in females passage of clots during their menses? And if yes, why? If no, why?
So usually because of the
fibrinolytic nature of like menstruation. There is a lot of fibrin, whatever.
Beautiful answer. Love the
Usually
answer.
there is no clot production, but if there is increased bleeding which overwhelms the capacity of fibrinolysis, there can be passage of clots.
Excellent answer. Great answer. I love this answer. Okay, so now you have 2 more minutes for this case. Give me the management part. What are your options?
So the management will depend on whether it's symptomatic or asymptomatic.
She is symptomatic. She has pallor.
Sir, so again, it will depend on whether what type of fibroid it is, whether it is submucosal, intramural, or subserosal fibroid.
Okay. So, how do you stage it? What is the name of the staging? Don't tell me the staging, just the name.
F5 staging.
Figo staging. Okay, correct. So, in this case, what is going to be your management? The best plan that you're going to tell the patient.
So since she has prolonged heavy menstrual bleeding, first we will treat that with medical
Very good.
management. So the three drugs we use are tranexamic acid, progesterone, and OC pills. So we'll give
Hmm.
that. If that does not work, then we can also give GnRH antagonists and agonists. We can also give. They will reduce the estrogen, and to reduce the progesterone, we can give mifepristone and olipristal. And if the medical management does fails, or if it is a submucous fibroid or a fibroid which is larger than 5 centimeters, we will have to do myomectomy. So it can be hysteroscopic or laparoscopic. So hysteroscopic if it's type 0 or type 1, and if laparoscopic if it's beyond type 2.
Okay, correct. What is going to be your best management for this patient, though? You're telling me about all the possible approaches. What is the best thing? The patient just tells you, मुझे सबसे अच्छा क्या आप बताओ मैं सबके लिए ready हूँ. What is that one thing that you would do? Medical or surgical? And if surgical, then conservative or radical?
So surgical, we'll go for laparoscopic myomectomy.
Correct. Laparoscopic myomectomy. And at this point of time, you can possibly consider total abdominal hysterectomy as well, given that it's a large fibroid. But yeah, I'll give that to you. She's not yet postmenopausal, so a myomectomy is going to be a good enough thing. A point here to be noted, everyone is going to ask me, so why not directly do a hysterectomy? Because this patient will have a risk of recurrence of fibroids. Remember that your ovaries, I'm talking about the ovaries, I know what I'm talking about. It is the ovaries have 20% of blood supply that comes from your uterine arteries and 80% comes from the gonadal ovarian artery that comes from the aorta. So whenever you're doing a hysterectomy, you're cutting off 20% of the blood supply that comes to the ovaries. And hence, your patient is going to have those menopausal symptoms much before she would have otherwise had if you would have kept the uterus. So your hysterectomy is actually also affecting your ovarian vasculature, which is why we do not do unnecessary hysterectomies in young patients. And by young, I would want to say anything below 50 years of age, preferably. At least 45. Do not try to attempt a hysterectomy because those menopausal symptoms, and by menopause, I do not mean a cessation of bleeding. By menopause, I mean osteoporosis, mood swings, hot flashes, all those things, atrophic vulvovaginitis, all those things will start appearing much earlier. So yes, absolutely, it's a 20-week size mass. I will want to do a myomectomy, laparoscopy or hysteroscopy. Of course, this doesn't seem to be a see, it's a 20 weeks mass, so you cannot be mentioning hysteroscopy because hysteroscopy से 20 weeks का कैसा निकालोगे? वो laparoscopy से ही निकलेगा. So yes, so that is pretty good diagnosis. So it is uterine fibroid with laparoscopic removal or myomectomy. Great answers. Should we go on to the next case then?
Yes, sir.
Okay. So the next case, it is a 30-year-old female. I hope you can read the case. I'll just enlarge it here. It's a 30-year-old, married since 10 years, female, para 3, living 3. She has come to you with discharge per vaginum, lower abdominal pain, and fever since 1 week. She has last menstrual period that was 10 days back. She has cycles of 4 to 5 days and has normal interval, regular moderate flow, and painless cycles, so no dysmenorrhea. Obstetric history is she has all gotten her normal vaginal deliveries, full term normal deliveries, and tubal ligations done. On per abdominal examination, there is tenderness in the lower abdomen. She has per speculum examination that shows purulent discharge from the cervix, and the vagina is healthy. Uterus seems to be of normal size, anteverted tenderness in both the fornices, no mass appreciated in the fornices. What's your first differential and how do you proceed?
Sir, chlamydia, PID due to chlamydia.
Do not give the, never give the organism because that is something that can vary significantly. Oh, PID is a good answer. Acute or chronic, what do you think this is?
Sir, acute because the history is less than 1 week.
Correct. So this is an acute PID. What might be your second differential? Might, possibly might, although it is not.
Sir, an abscess.
Uh, Very good. So a complication of PID, that is a tubo-ovarian mass or a tubo-ovarian abscess. Very good. Okay. What are the organisms that cause PID?
So chlamydia, gonorrhea, tuberculosis.
Correct.
Postmenopausal E. coli and actinomyces in IUD users.
Very good. इंडिया में बहुत कॉमन कॉज कौन सा है?
Tuberculosis.
Tuberculosis. Okay. How would you determine which is the organism?
So we can send a culture of the very first menstrual blood.
For this patient.
Sir, culture.
What? Which culture? Your voice was just cut through.
Urine routine and culture.
Yes, correct. So urine routine and culture, but something more as well. You can just send a discharge.
Endocervical swab.
Very good. Endocervical or a high vaginal swab, wherein the collection from that cervix, that discharge from the cervix is getting collected. You mentioned something about the first menstrual blood. That's a great answer. But what is it for? For which organism?
So for tuberculosis
Very
mostly.
good. So why do you send the first menstrual sample?
So because tuberculosis is an aerobic organism, so it mostly resides on the surface of the endometrium. So when the first blood is shed, the tubercular bacilli can also come along with it, and which we can detect.
And we see the tubercles in the blood.
Amazing answer. That is a brilliant answer. Perfect answer. Aerobic respiration के वजह से superficial layer में वो रहते हैं. But there's a problem to this. As a female, she's never going to know when does she get her first menses. She'll probably bleed, and then she would know यार ये तो blood चला गया. Hence, it is very difficult to get the first sample. So, what is the second best way of knowing that this patient has tuberculosis?
So hysterosalpingography.
Okay, histosalpingography, very good. What are the various changes that you see on histosalpingography? Could you tell me?
Sir, there can be filling defects in the uterus itself, like in Ashelman syndrome. It can be fully obliterated, like in Netter's
Very good.
syndrome. Then there can be beaded appearance of the fallopian tubes.
Okay.
Then there can be
Bilateral cornual block, commonly seen.
Okay, but that is going to be seen in a lot of things, so not specific to TB.
there can be tobacco pouch appearance of the fimbriae.
Very good. Yes,
And
correct. What else?
like hockey stick appearance after the tobacco pouch
Golf club, not hockey stick, golf club appearance.
appearance. Yes, sir.
Hmm.
And lead pipe appearance of the fallopian tubes.
Very good. Excellent answer. Beautiful answer. So it starts with bead pipe because there are various different areas of fibrosis that first occur in the fallopian tube. Once all of those areas coalesce, they form a single lead pipe appearance. That's a very small tube with hardly any patency in the fallopian tube. Tobacco pouches, basically all the fimria come together and toxin fluid and all the abscess and all those things start filling up inside those fimria. So it forms like a swollen up bag like a tobacco bag. So tobacco bag is basically a small bag that a lot of people carry for carrying their tobacco in it, old timers leather bag. So it's going to look like that. Okay. What is your treatment of choice for this patient? This patient doesn't seem to be a tuberculosis patient. So what is your treatment of choice for this patient?
Sir, we'll give the kit for
Which kit?
the yellow kit for
Very
PID.
good. What are the contents of yellow kit?
Sir, it has tablet metronidazole,
Hmm.
all tablets, doxycycline, and cefixime.
Okay, could you just tell me the doses?
Metronidazole 400 milligram BD for 14 days.
Correct.
Then cefixime 400 milligrams one dose, and
Okay.
doxycycline 100 milligrams BD again for 14 days.
Perfect answer. Great answer. What if she doesn't respond to yellow kit and she still has fever? And in fact, she's having high grade fever now. What would you do?
So we could consider admitting the patient.
Okay, and
Uh, Give IV antibiotics.
very good. Which are the IV antibiotics of choice for patients with PID?
Sir, IV cefixime?
Aya, IV cefixime. Do you even get IV cefixime?
Sorry, ceftriaxone?
Ceftriaxone, yes, correct. What else?
So doxycycline, again, IV.
Uh, okay, IV doxycycline. Any other drug? One very important drug.
Metronidazole also.
Okay, what apart from that? One more, very important. An aminoglycoside.
Amikacin?
Gentamicin. Gentamicin is an excellent
Gentamicin.
drug that you give for gram-negative cover. Okay, great answers. Excellent answers then. In this case, purulent discharge from the cervix, basically she is having all those, the triad of PID that we have seen over here, discharge per vaginum, lower abdominal pain and fever. Apart from that, tenderness in the lower abdomen is very classical of PID, and there is tenderness in both the fornices. Why is the tenderness? Because your entire adnexa includes your fallopian tube and your ovaries. They are inflamed, and because of the inflammation, the mesosalpinx and the mesoovarium is getting stretched. So whenever you try to touch it, there is even further pulling of these ligaments and of this peritoneal layer, which gives rise to the pain in the fornices. So the inflammation and the pulling of all these peritoneal folds is what is going to give rise to that pain. Currently, they have mentioned no mass appreciated in both the fornices, so she probably has not yet developed tubo-ovarian mass or a tubo-ovarian abscess. Tubo-ovarian abscess can be a surgical emergency. You may have to operate to decompress the abscess and remove it. But right now, she doesn't have tubo-ovarian abscess. So absolutely correct. This is a case of PID, and yellow kit is going to be her management. Great answering. Next case, should we?
Yes, sir.
Okay. So next case is a 46-year-old lady presented with excessive pervaginal bleeding during menstruation since the last 6 months. Her LMP is 14 days back. Past menstrual cycles, they seem to be normal, but she has clots and they are also painful. Now, on examination, she does have pallor, but her pulse and BP is normal. On per abdominal examination, it is soft. There is no guarding tenderness, rigidity. On per vaginal examination, the uterus is enlarged, 8 to 10 weeks, with tenderness, but normal mobility. What's your differential and what's your diagnosis?
Sir, adenomyosis?
Correct, yes. Adenomyosis.
Endometrial hyperplasia and endometrial carcinoma.
Okay, I rather would want to stick with endometrial, no, with adenomyosis, but second and third differentials are good. What will rule out endometrial hyperplasia and endometrial carcinoma in this case? Which are the findings in this history or in this case that will rule it out? Am I audible?
Yes, sir, we were just thinking. Uh,
Try looking at the examination.
sir,
En-
sir, the enlarged uterus
But that enlargement can also be seen in endometrial carcinoma. It
with
is something
normal
very specific.
normal mobility.
and tendon.
Normal mobility, good. Normal mobility. What does that technically rule out?
Any
Invasion.
yeah, invasion and fixation.
Any invasion, correct. So any invasion of your parametrium, so an advanced stage endometrial carcinoma is going to rule out is going to be ruled out because there is normal mobility. There is one more finding that rules out your other differentials.
So tenderness.
Tenderness, correct. So tenderness is very classical. The very classical description of adenomyosis on pervaginal examination is a bulky uterus. Bulky is just slightly more than normal size and tenderness, absolute tenderness. Okay, so what is adenomyosis exactly?
Sir, adenomyosis is migration of the endometrial tissue inside the myometrium.
Okay, correct. What is it a part of? Which spectrum of disorders is it a part of? यही अगर एंडोमेट्रियम बाहर चला गया तो क्या होगा?
Endometriosis.
Endometriosis, correct. So adenomyosis is going to be infiltration of your myometrium with your adenomatic tissue. Why should that lead to heavy menstrual bleeding and dysmenorrhea?
Sir, because the endometrium quantity is increased and there's hypertrophy and hyperplasia of the tissue, and dysmenorrhea is because of the myometrial hypertrophy and hyperplasia. So,
Mm, not really. So, whenever there is adenomyotic tissue in your myometrium, your glandular tissue in your myometrium, every time you have menses, that tissue is going to bleed inside the myometrium. And these bleeding areas are going to stretch the myometrium, they're going to pull it apart. That is what actually gives rise to this pain. So that is the reason why there is going to be dysmenorrhea. Apart from that, this blood is also going to prevent the actin-myosin complex formation and the normal contraction of the uterus. So if the uterus is not contracting normally, the blood vessels that supply the endometrium, which have to be constricted at the end of menstruation so that the bleeding is limited, they are not going to work that way because the blood is preventing the muscular action, which is why there is going to be heavy menstrual bleeding as well in these patients. What's your management?
sir, we can do a total abdominal hysterectomy.
Are you sure
Con-
that total abdominal hysterectomy is going to help? There's a question that I asked you at the beginning of this case. What is it a part of?
Endometriosis.
Endometriosis. So, if there is adenomyosis, there is a chance that she may also have superficial endometriosis inside the pelvis, which you may not see with your naked eye. So, if you go ahead with an abdominal hysterectomy, of course, you would treat a problem of heavy menstrual bleeding and your dysmenorrhea, but you may still leave behind a few endometriotic deposits that may give rise to pain even after hysterectomy. So, hysterectomy is going to be when your initial therapy fails. What should be your initial therapy?
So same than medical management like NSAIDs for pain relief, tranexamic acid, hormonal therapy.
Correct.
Repeat
So,
stems.
hormonal therapy. Which exactly hormonal therapy is going to be highly effective in this case?
We can give the Mirena LNG IUC.
Excellent answer. That is the answer that I'm looking for. For all patients with adenomyosis, in fact, Mirena is one of the best things that you can do for them. Why? You insert a Mirena for a 45, 46-year-old female, that Mirena is going to act for 5 to 7 years at least. So it takes her towards the point of menopause. And post menopause, there is going to be no estrogen, no progesterone in the body. There is going to be no stimulus to the endometriosis or the endometriotic spots, including the adenomyosis, which is why her pain is going to resolve on its own whenever the menopause comes around. But I have a question for you right now. Imagine that this same patient has grade 2, stage 2 or stage 3 of endometriosis concomitantly, and you have inserted a Mirena, and she reaches her menopause. Is menopause going to cure her problem of pain?
So the cyclical pain won't happen.
Okay, correct. The cyclical pain won't happen. So, is there going to be any sort of pain? And what is that pain called as?
So would there be chronic pelvic pain?
Yes, chronic pelvic pain. What would the cause be? Your endometriotic tissue तो is now rendered ineffective. तो उससे तो
Because
pain होने
the inflammation and scarring because of the
absolutely
that
correct
happens.
Causing
answer.
adhesions.
Yeah, the adhesions that have already occurred because of every month में वो जो छोटा छोटा endometriotic tissue से bleeding होता था in the pelvis, उसके वजह से inflammation की वजह से there is chronic inflammation and chronic inflammation का outcome is always going to be fibrosis. So that fibrosis is going to stretch the peritoneum and that is going to give rise to chronic pelvic pain, which is why a lot of people when they say that menopause is going to heal your endometriosis, it doesn't. Your endometriotic spots will become dormant, but the adhesions that they have caused are still going to give you chronic pelvic pain, and hence we will have to carry out a surgery in these patients to do adhesiolysis and free that pelvic pain. Okay, so finally, your diagnosis is adenomyosis, and your treatment of choice is going to be progesterone support, either in the form of Mirena, which will ensure good compliance, or oral progesterone. Okay, if this fails, if the problems persist, then we can think of abdominal hysterectomy. But more than that, it will be better if you do it laparoscopically so that we can even look for other endometriotic symptoms, endometriotic signs inside the pelvis. So laparoscopic hysterectomy if your medical therapy fails for her. Okay. So next case,
Yes, sir.
last case for you. You still have 7, 8 minutes left for you. So the next case is it's a 45-year-old female Para 4 living 4, tubal ligation done. Complaints of post-coital bleeding since 1 month. No other complaints. Menstrual history is she has had her last menstrual period 15 days back. She has 2 to 3 days of cycles at a normal interval of 30 days approximately. They are regular, moderate flow, and painless. Her obstetric history is of Para 4 living 4. All are FTNDs and tubal ligation was done. On examination, the per abdominal findings are that it is soft. There is no mention about guarding tenderness or rigidity. The post speculum examination shows that there is a cervical growth that is present. There's a 1 into 1 centimeter on the anterior lip of cervix. It bleeds on touch and the vagina is not involved. Rectal mucosa is free. Parametrium is free. What is your diagnosis? First diagnosis.
Sir, based on the history of uh, postcoital bleeding and growth on this, and the examination showing a cervical growth, our
Mhm.
first diagnosis would be cervical carcinoma.
Correct. And what would be the stage given the findings that you have?
Sir, uh, sir, 1B.
Okay, you're very close. I love your answer of 1B. It is 90% there. Would you want to give a 1B1 or 1B2 or 1B3 wala diagnosis?
1B1 considering it's less than 2 centimeters.
Correct. Excellent answer. So it is 1B1. What made you think that it may not be into stage 2 or stage 3? Is there any such finding that you can see over here?
Sir, the vagina is not involved, so it's not stage 2.
Okay, and stage 3 and 4?
The parametrium is free and the
Very
rectal
good.
mucosa is free.
And the rectal mucosa is also free. So that technically rules out stage 2, 3, and 4. So your staging is not just on the basis of what is present, but also on the basis of what is absent. It might so be the case that you have only a 2 centimeter mass, but it is extending into the parametrium or the rectal mucosa is also included through metastasis. That will upstage your tumor. So always remember that also check for the absent finding. Great. What is going to be your management for this patient?
Sir, investigations also or just man?
Yeah, investigations will do. Definitely tell me.
Sir, so cervical cancer, so we'll do the biopsy, colonoscopic
Colposcopic guided biopsy.
colposcopic.
Colonoscopy,
Sorry,
great.
colposcopic guided biopsy.
कॉल्पोस्कोपी कब करते हैं whenever you cannot see the lesion. यहाँ पे दिख रहा है 1 सेंटीमीटर का
We can
लीजन
do
so I do
punch
not really
biopsy. Punch
yeah
biopsy.
punch biopsy can be done excision biopsy also can be done और ठीक है मतलब कोलोनोस्कोपी का कॉल्पोस्कोपी का जरूरत नहीं भी कोलोनोस्कोपी बोला कॉल्पोस्कोपी का जरूरत नहीं बिकॉज दैट इज ओनली फॉर लोकेटिंग द लीजन्स दैट आर वेरी स्मॉल टू बी सीन बाय द नेकेड आई so normal biopsy will do okay next hello am I audible
Sir, CBC for a preoperative workup.
ओके ये कैसा पांचट एग्जामिनेशन की चीजें बोल रहे हो करने के लिए तो पूरा हम प्रोफाइल कर सकते हैं एलएफटी भी करूंगा मैं आरएफटी भी करूंगा बट व्हाट इज मोर स्पेसिफिक समथिंग जस्ट लाइक यू मेंशनड अबाउट बायोप्सी समथिंग that would confirm that it has not spread.
MRI pelvis, sir.
Yeah, MRI is going to be a good measure. You can even think of doing a PET CT to look
PET
for distant metastasis.
metastasis or USG pelvis also.
USG is a good modality, but then it is not going to give you anything more than what your examination has already given you in a cancer patient. I would rather go for higher imaging studies. Okay. Your management?
Sir, based on the stage, we can do a radical hysterectomy,
Correct. Okay.
a type 3.
And type 3, okay. Type 2 is also okay. Type 3 is also okay.
Yeah,
If your female would have been a 25-year-old female, unmarried, what would your treatment have been?
sir, radical trachelectomy.
Radical trachelectomy. Okay. What is the complication of doing a radical trachelectomy on her fertility whenever she conceives?
Sir, because the cervix is removed and there is like internal os is injured.
The uterus is
Okay.
pushed to the vagina, so then she will have cervical incompetence.
Cervical
Not
incompetence.
cervical.
You're there. You're correct about it. Cervical incompetence is one thing. Imagine I already did a laparoscopic abdominal circulage for her. What apart from that? Something in labor?
She'll have to go for LS.
She won't be able to have normal vaginal delivery. She'll have to
Why?
do SCS because the cervix is removed.
Yeah, because the cervix is removed, there are no smooth muscle fibers for it to dilate. So it is going to be fibrotic. So she's going to have cervical dystocia. So she won't progress and she will go into non-progress of labor. And hence, you would want to do a cesarean section for this female. And simultaneously, you may also consider post-cesarean section to remove her uterus. Okay, to prevent recurrence. Finally, a question on this. Tell me a bit about your vaccination that can prevent, and what are the high risk DNAs that are going to cause cervical
So
cancer?
the high risk ones are HPV 16 and 18 for cervical cancer.
Okay, what else?
So 31, 33 also.
Okay, okay, 31, 33. Okay, and what about vaccines?
Sir, Gardasil, Cervarix, Gardasil 4, Gardasil 9 is also there.
Okay,
Cervivax, Cervarix.
सर्विवैक. ओके ग्रेट. इंडिया ने जो अभी इंडिजिनस इंट्रोड्यूस किया हुआ है उसका नाम क्या है? सर्वावैक. उसमें कौन से आते हैं, कवर करता है वो, विच ऑल वेरिएंट्स?
So the four main strains 6, 11, 16, and 18.
Okay, so basically it is a quadrivalent vaccine. Correct. ठीक है. What is the ideal age for giving and should it be given to girls or boys?
Sir, it should be given to both. It should ideally be given at a younger age, less than 15, because only 2 doses need to be given. If it's given after that, then you have to give 3.
Okay, is that the reason why you have to give it at a younger age?
No, so that because before we have to give both the doses before coitarchy.
Before the coital, oh, coitarchy. That's a new term. I don't know about. Is that really a term? I don't know. Okay,
Yes.
but coitarchy. Okay, fine. So before the onset of first coital activity, you have to give it. And yeah, that's a great answer. So we finished with 4 cases of yours. That was absolutely great answering. You've stuck to the time limit. You have answered everything in 31 minutes. That is pretty good. So well done, Apoorva. Well done, Uditi. Great answer.
Thank you, sir.
Okay. So next team, Mohak, Srilekha, Darshan, Mohit, Vineet, Sumedh. Who would want to do? Quickly, just volunteer.
Yeah, we would like to go ahead.
तो कौन बोला? विनीत ना?
Yeah, Vineet.
Okay, fine. So half an hour for your cases and okay, let's begin. So the first case for you. Let us begin.
Oh,
Should
yes.
we?
Yes,
Okay.
yes.
So it's a 13-year-old female who is a 7th standard student, came with continuous bleeding since 20 days, who has attended Menaki at the same year, in the same year, 2 months back. She has history of excessive bleeding even in a previous cycle. On examination, she has excessive severe pallor. There is no thyroid swelling, no galactoria. Her per abdominal findings are that it is soft. We cannot do a per vaginal examination because she is, of course, a young patient and is unmarried. Her per rectal examination, I'm just telling it in advance, shows no abnormality. What would you do next? What is your first differential and how do you manage?
Since she is a 13-year-old girl who has just attained her menarche 2 months back, uh, looking at the symptoms and the case, it looks like a case of atypical uterine bleeding. And based on the examination findings, like there is since we cannot do a pervaginal examination in a virgin female, and per rectal findings which you have given, and it seems like it is mostly atypical uterine bleeding due to a non-structural cause. So she since she is and just has achieved her puberty, it seems like it is most likely a case of puberty menorrhagia rather than coagulatory disorders.
Okay, correct. One second. What could you just repeat your last statement?
The last statement was that it's mostly puberty menorrhagia, and the second differentials would be the coagulopathies, which would then be Wall-Willebrand disease and all those.
Very good. In fact, that is your first differential at this point. Your
Yes.
puberty menorrhagia is going to be mostly because of, first of all, coagulation defects, and secondly, what is going to be the second differential at this point? What is the other cause of it?
Ovulatory
Please.
cycles during first 2 to
Very
3.
good. Anovulation. Anovulation कैसे होगा? So ठीक है. Just tell me, why should anovulation lead to excessive bleeding?
So during anovulation, there is there is growth of the follicle, but the follicle does not rupture. So there is continuous stimulation of the endometrium due to that, and
It is
No
basically
progesterone, basically.
lead to bleeding, and hypothalamus pituitary ovarian axis is yet to be matured.
Correct. So basically, you don't have a corpus luteum to produce progesterone. So you do not have anything that will control the unopposed estrogen associated proliferation of your endometrium. That is why anovulatory cycles, same case goes with PCOS, is going to lead to heavy menstrual bleeding in these patients. How long does it go on for since menarche maximum?
3 years.
Okay, 3 years. A few people even say up to 7 years. So 2 to 7 years is that ideal period until which it can go on for. There are two. There's a sentence over here that is very significant, which pertains to this case. No thyroid swelling, no galactoria. Why have they mentioned this?
So So basically, thyroid swelling is means it can be a case of hypothyroidism. So if there is a hypothyroidism, so there would be increased feedback to the hypothalamus and the pituitary gland. So there would be increased secretion of thyrotropin releasing hormone, which would stimulate TSH as well as prolactin. So basically, it has negative feedback on FSH and
Okay, correct. Also, how could you just tell me now that you have anyway mentioned about it? Could you just tell me how does hypothyroidism also lead to anovulation?
so there's a negative feedback on the gonadotropic hormone, so there will be no LH surge and no ovulation.
Ulta, it is the other way around. Your TRH is going to stimulate your GnRH, and that will lead to a loss of pulsatile release of GnRH. That is
Yes.
actually the reason. Yeah. So the pulsatility is going to be lost, which is why your FSH-LH is not going to be secreted, and hence you will have anovulation. Okay. How do you manage this patient? Your management does not just include your diagnosis, I mean treatment. Remember that you also need to include your investigation. So how would you manage it?
So basically, since she is like Hubert, we'd like to go with basic investigations, and since she's having pallor and blood loss, we'd have to do a complete blood count, hemoglobin levels, and then we have to do the coagulation profile, that is bleeding time, clotting time, activated partial thromboplastin time. Also, we have to estimate the menstrual blood loss if we can, and we have to detect any coagulopathy if there is, and we have to specifically go for if there is any family history of coagulatory disorders.
Okay. What are the various coagulopathies that you would look for, and what are the tests for that?
So the basic tests are BT, CT, and APTT as mentioned before, and the coagulopathies that we would be looking for are
Von Willebrand disease, prothrombin deficiency, hemophilia, and thrombocytopenia.
Prothrombin deficiency, anything? No, no, there's a different term for that. Prothrombin gene mutation is a better word.
Okay.
Okay, what else?
uh, that's all.
Okay, anything that you're missing. You have mentioned everything but one thing. Very common. One
Hemophilia.
coagulopathy.
Hemophilia.
Okay, hemophilia is one, but something much more common.
Leukemias.
Okay, okay, that is a good answer. There is one more thing. With regards to, I'll just give you a hint, platelets.
Sir, there might be immune thrombocytopenic
Ah,
purpura.
correct answer. ITP. Great answer. Correct. Okay. So now tell me, how would you manage her?
Sir, basically, with blood loss, so if we have to see what are her exact hemoglobin levels. If her hemoglobin levels are less than 10 gram per day, we have to start with OC pills for 3 continuous months without a break. If her hemoglobin levels are more than 10 grams per day, we still have to start the OC pills, but it would be a 3 week and then followed by 1 week gap, such for 3 cycles.
You've absolutely erred at this point. You wouldn't be prescribing OC pills to a 13-year-old female as your first line. That is probably your second or third line. And definitely not for 3 months. देना ही है OC pills for second line है, and you can only give it for a month. Why? Your first line is always going to be progesterone for this female. Why? And there are two halves to your treatment. First is to stop the bleeding, and the second is to correct your cause. That is your coagulopathy or your hypothyroidism, which is not your case, or coagulopathy in your scenario. So, how would you manage this now? Am I audible?
Yes, sir. Yes.
Okay, so the fact that you mentioned estrogen, remember your estrogen is going to cause premature closure of your epiphysis.
Yes,
She is a young female, 13-year-old girl who, if you end up giving her estrogen for such a long time, every single month is going to be important for her growth. She is actually at her peak growth potential wala years. So you cannot give her estrogen as a first line drug. तो फर्स्ट लाइन कौन सा ड्रग देगा तू प्रोजेस्टेरॉन होगा वो ओके
yes.
तो प्रोजेस्टेरॉन देगा अगर प्रोजेस्टेरॉन से कंट्रोल नहीं हुआ तो ओसीपिल्स देगा बट दैट इज ओनली गोइंग टू बी फॉर एन एक्यूट कंट्रोल apart from that any other drugs that you would give to stop bleeding.
So tranexamic acid as always every female.
Very good. Tranexamic acid is a good drug. Okay, fine. What about the other part? How do you treat the cause?
So the treatment will vary depending on the cause. We will, if it is factor deficiencies or Paul Miliband disease, we might go for vasopressin and then loading her with giving her the factors that are deficient.
Plus, we have to correct the anemia with if since it would be an iron deficiency anemia, then oral iron needs to be there. And if there is too much blood loss, blood transfusions can
Blood
also.
transfusion would be required. Okay, correct. What? How do you treat ITP?
Yes, so for ITP, we would firstly, the first would be intravenous IVIGs could be given, and if it is refractory, then splenectomy can be done.
Splenectomy for ITP. Okay, उसके पहले तो ये भी तो बोल सकता है oral prednisolone. Prednisolone and steroids, they are going to suppress your immune potential, immune response. ठीक है. So that's a good answer from your end. Remember, never give estrogen to young females, and if you want to give it, only give it for a short course. The
Yes.
book of Speroff also mentions that if your bleeding is still not controlled on oral estrogen, so for 5 to 7 days, you can also give IV estrones. IV estrogen also can be given, but that has a high thrombogenic potential. So you have to give it very carefully and you have to keep an eye on your DVT. That is going to be your last possible measure. Okay. So that's your answer for now. Okay. Then let's go to the next case. Okay, so next case, it's a 31-year-old female who has had multiple early pregnancy losses. She has a parity score of abortion 4 in her 9 years of marriage. The first one was a spontaneous abortion at 2 months of gestation. The second one was again a spontaneous abortion at 3 months of gestation. Third again at 3. Fourth again at 3. So all of them have been between second and third month. Her last menstrual period doesn't matter over here actually because it's an old case. She has also had one episode of venous thromboembolism after her fourth pregnancy. Okay, so VT ho chuka hai. General examination shows that she is hypertensive, not hypertensive, slightly raised blood pressure. And systemic examination is normal. Gynecological examination is also normal. Investigations are not given. What's your first differential at this point?
So looking at the case, given that she's 31-year-old with recurrent pregnancy loss and venous thromboembolism, and the months in which those losses are, so it's probably the first differential would be Apla syndrome. And
Okay, correct. Second,
second,
So
it could be structural anomalies of the uterus.
Mullerian abnormalities.
Mullerian abnormalities.
no, I would want a better second differential.
Uh,
Look at the past history. That is the biggest giveaway for you. तेरे यूएसजी किए हुए है हर प्रेगनेंसी में अगर कुछ स्ट्रक्चरल एबनॉर्मलिटी होता तो वो बताते ना तेरे हिस्ट्री में सेप्टेट यूट्रस एंड ऑल ऑल्सो वेरी रेयरली सेप्टेट यूट्रस से ज्यादा होता है इनफर्टिलिटी recurrent pregnancy loss is slightly lesser common than infertility plus USG में उन्होंने कुछ दिया नहीं है so something much more common I would want to consider uterine abnormality but as my third or fourth differential एप्ला अगर फर्स्ट है तो सेकंड क्या होगा
other thrombophilias like factor.
excellent very good what are those thrombophilia
So there are factor V laden mutations are there. Then protein CNS deficiencies can be there. Antithrombin 3 deficiency can be there. Yeah, that's all.
Okay, protein CS deficiency, antithrombin deficiency, correct. Prothrombin gene mutation, leadin 5 mutation. And anything else that you're missing out on? Thrombophilias?
SLE?
Not really. That is going to lead to secondary APLA. So not really. Any classic thrombophilias? MTHFR gene mutation. Also, your homocystinemia. These two things also will lead to thrombogenic potential. Okay. Uh, Third, fourth differential. Anything at the third position, as I said, your uterine abnormalities would be at the fourth location. Anything at third?
Hypothyroidism?
Okay, great answer. Excellent answer. Endocrinological causes. Okay. Anything else? That's a good answer, by the way. Uncorrected diabetes or anything endocrinological. Uncorrected diabetes or uncorrected hypothyroidism. Great. What else?
Um, so we can ask for her other family history and personal history on smoking.
No. There is something that I ask after asking about her marital history. Something very common.
Consanguinity?
Yes, consanguinity. Now, by the way, latest guidelines do say that consanguinity is not that important a risk factor, but consanguinity से क्या होता है? You could have unbalanced translocations. Aneuploidies का risk, chromosomal aneuploidies. That is in fact going to be one of your differentials at this point of time. कि बार बार abort हो रहा है, second, third month में ही हो रहा है, second, third month में हो रहा है. इसका यही मतलब है कि the baby is not even reaching that point of NT-NB scan. So first 10 weeks में ही हो रहा है. So chromosomal aneuploidies, recurrent aneuploidies is going to be one more differential for you. Okay, so these are your 5 biggest differentials. How would you manage it?
So first we'll have to investigate her.
Hmm.
Uh, so for investigations, we will have to look for antibodies in the blood, which are specific for APLA.
Hmm.
And after that, we will have to
What are the
rule out.
antibodies that are specific to APLA?
Beta 2, give me a minute.
तेरे
It's
अमाइलोडोसिस में जाता है बीटा 2 माइक्रोग्लोबुलिन, तो यहाँ पे जाएगा बीटा 2 ग्लाइकोप्रोटीन.
yeah, beta 2 glycoprotein is there, antiphospholipid antibody is there, and
No. Antiphospholipid antibody तो
anticardiolipid antibody.
okay. What else? Last.
It's done. Beta 2 microglobulin cardiolipid.
अरे बीटा 2 ग्लाइकोप्रोटीन माइक्रोग्लोबुलिन नहीं. Lupus anticoagulant.
Okay, yeah.
Lupus anticoagulant. So basically IgG and IgM of the earlier two former two antibodies and lupus anticoagulants. Okay, that is for your APLA. What else? How do you investigate the other causes?
So coagulatory profile needs to be done again.
Okay.
Then for thyroid profile needs to be done, TSH 3, T3 and T4 levels.
Okay. You mentioned about thrombophilia profile. What do you exactly do in coagulation or thrombophilia profile? ठीक है, not an issue. Next तेरा आता है chromosomal aneuploidies. What would you do for that?
So for that, we'll do maternal and paternal karyotyping.
Okay, maternal and paternal karyotyping, excellent answer. You would be able to see multiple unbalanced translocations in them. Balanced
Yes.
translocations in them, which are resulting in unbalanced translocations in the embryo. Okay. And lastly, for your uterine anomalies, best.
Yeah, so transabdominal USD scans.
Okay, is there a better answer that you would want to give for USG?
Hysterosalpingography.
Okay, hysterosalpingography, good answer. But then what is the best test that you would do for Mullerian abnormalities?
MRI.
MRI is the best, but MRI is resource intensive. So even a 3D or a 4D USG is going to be a good screening test for the diagnosis of Mullerian abnormality. Okay, how do you treat it?
So again, the treatment is based on the cause. So So,
Yes.
we'll have to then firstly we'll have to treat the thrombophilias or the Apla syndrome. Secondly, the
How
uh,
do you treat it?
yeah. So don't I don't remember, sir, actually.
It's okay. Warfarin or heparin has to be given for them. Mostly heparin, because heparin is going to
But
bind to these antibodies as well.
we'll have
Okay,
to
what else?
actually criterize by Sapporo and then give heparin and etc.
What else? For the other diagnosis for thrombophilia, also similar way of managing it. What about aneuploidies?
Aneuploidy, we can only counsel them.
No, you can counsel them, or what you can do is you can do in vitro fertilization. You can take their embryos, you can select the embryo that is causing the problem, and only the good embryos are going to be implanted. If not, then you can also take a donor sperm or donor ovum or both donor and implant it in this female. So counselings are better. You can have this pre-implantation genetic diagnosis that you can do. PGT. Okay. And for uterine anomalies, what is the commonest uterine anomaly that will cause recurrent pregnancy loss?
Septate uterus.
Septate uterus. What is the management?
Septostomy. Septostomy.
Septostomy is a treatment for TTTS. TTTS में होता है, इसमें नहीं होता है, इसमें it is septal dissection. ठीक है, that's fine. So the answer to this is going to be all the recurrent pregnancy losses के causes and according management. ठीक है. Next, please. Okay, so it's a 28-year-old lady who has come with irregular menses. She has had her LMP 6 months back. Her last menstrual cycles are showing that she has scanty menses that lasts only for 1 day every 4 to 5 months, and they are painless since 2 years. She has history of one full-term vaginal delivery, and that is followed by a dilation and curettage that was done 2 years back for first trimester MTP. On examination, everything is normal. Per vaginal examination is also normal. Ultrasound shows a normal uterus with an endometrium of 2 millimeters. What's your first differential?
So can we read it for 2 minutes?
Yeah, sure, no problem. I would request everyone in the audience to please not answer so that the teams can answer. Please, it's a request. It's very easy to be sitting back and answering it. I would request not to answer.
पहला differential. So
Yeah, sure.
first differential could be Asherman syndrome. It could also be an ectopic pregnancy.
Okay, correct. So your first differential is actually the correct answer. And ectopic pregnancy, देख तेरा 4 or 5 months से नहीं होगा रे scanty bleeding. So ectopic is literally the answer that you wouldn't want to. And USG किया है तूने? USG पे ectopic तो दिख जाएगा ना अगर
Yes.
4-5 महीने से है तो. एंड
Yes.
पेनलेस सबसे बड़ा तेरा इसमें लाइन है. पेनलेस है वो. पेनलेस कैसा रहेगा तेरा ectopic 2 साल से? So
Yes.
look at the history. Your ectopic is going to give you a very acute history. 1-2 महीने का history रहेगा. Okay. So Asherman's seems like the most likely diagnosis. What are the parts in this history that made you think of Asherman?
So dilatation and curettage done 2 years back. That was the
Correct.
just hint. Uh, Apart from that, the uterine size is normal. Fornices are
Okay.
free.
And
Okay.
Endometrium is only 2 mm.
Is only 2 mm. So could you just tell me or could you give me a brief idea about what are the ideal endometrial sizes across 3 phases of cycle?
We don't know, sir.
Okay, so no problem. So whenever the female is menstruating, by the end of menstruation, that is day 4 or 5 of cycle, it has to be around 0.5 to 1 mm. उसके बाद में in the proliferative phase, it goes as high as up to 10 millimeters. It can go up to 10 mm as well, which is 1 centimeter. So 7 to 12 millimeters is normal in the proliferative phase, which it peaks at around 14th day of cycle. After that, in the secretory phase, it stabilizes and is back to around 7 to 10 millimeters. And when she starts menstruating again, it will shed off everything and give rise to menstruation, and again 0.5 पे वो वापस आ जाएगा. So that is how you would be able to know whether it is very thin or too thick endometrial hyperplasia. Okay, how do you manage this patient?
Sir, we have to do hysteroscopic adhesiolysis for the
Okay,
adhesions which have been there, and then we have to put a pediatric Foley's catheter because we'll be releasing all those adhesions. So we have to prevent, we have to see that they do not get re-adhered.
And also we have
okay,
to give estrogen and progesterone. Along with them, some centers also implant stem cells for the regeneration of the basal layer of endometrium.
correct answer. Okay, so could you tell me one precaution that you can take while doing a dilation and curettage to prevent this from occurring in future?
So we have to do a superficial curettage and not a deep curettage.
Okay, so there is a word that these people use, gynecologists use, which is something that you shouldn't be doing. Do curettage till a grating sensation is obtained.
Yes.
Absolutely not. You do not go for that grating sensation because by that you are eroding the basal endometrium. Your basal endometrium, which is going to proliferate your endometrium, if you're going to erode that, there is nothing that is going to be left. Okay. Asherman syndrome, that's a great diagnosis. There is one rare differential that may be possible at this point of time. Could you just think of it? One rare differential. If the history of MTP was not there and if it was not Asherman, thin endometrium, scanty menses, 20 or 30-year-old female.
Sir, it's a very vague answer. Premature ovarian insufficiency.
Very good answer. That's the answer. It's the rare diagnosis, which is why I said, how would you diagnose it? What are the tests?
Yeah, so we have to look for FSH levels basically. Yeah.
Okay,
And
so
transfer.
FSH level कितने रहेंगे? कम रहेंगे, ज़्यादा रहेंगे?
Sir, it would be FSH would be high, estrogen would be low, and also there might be some like as a clue, there might be some family history of premature ovarian insufficiency.
Very good. Any genetic test that you would want to do just for academic purposes? Any diagnosis that leads to premature ovarian insufficiency when a patient does not have any history of radiation, surgery, anything? One
Karyotyping.
diagnosis. Okay. There is one diagnosis that I'm looking for that leads to primary ovarian insufficiency or premature ovarian insufficiency. Something with regards to your X chromosome.
So karyotyping for Turner's was one answer. Apart from that, more answers you're looking for.
Yeah, one more answer.
Okay.
Fragile X. Fragile X syndrome leads to premature ovarian insufficiency because with Turner's, she would have not probably conceived because they usually have streak ovaries.
Oh
So
yes.
she would have had pehle se hi menopausal symptoms in 17, 18 years of age. Wouldn't have ever conceived. So it is Fragile X syndrome. Okay. So let's go on to the last case for you all. And the last case is okay. So it's a 35-year-old parato living to tubal ligation done. Uh, Complaint of pain in abdomen, abdomen distension since 3 months. LMP is 15 days back. The cycles are normal, moderately painless, मतलब moderately painful भी बोल सकते हैं. Parato living to previous to FTNDs. She has done a sterilization surgery. There is a cystic mobile mass measuring 15 into 10 centimeters in the lower abdomen, originating out of the pelvis. Per speculum is normal. Per vaginal examination, give the same findings in the left fornix. It is mobile and it is felt separately from the uterus. What's your differential and how do you proceed?
So give us a minute. We'll just read again.
Yeah, sure.
So ovarian cystic tumor could be there. It could be simple ovarian cyst or a ovarian malignancy. Those are the first differentials.
Okay, so how do you proceed?
Uh, with the investigations.
How
Yeah.
and which?
So per abdominal as well as transvaginal sonographies should be done.
Mhm.
After that, we can look for hysterosalpingography if there are tubal involvement or not. Then laparoscopic envisionation can be done while during a laparoscopy, we can look for the tumor and biopsy the tumor. And for all ovarian tumors, we have to do a histologic examination.
Okay, I just couldn't hear your initial part of management. Could you repeat it for me again? The
So,
first management part?
first is per abdominal as well as transvaginal sonographies, then
Okay.
hysterosalpingography, and then laparoscopic. Laparoscopically, we will view the tumor and biopsy the tumor, as biopsy has to be done for all ovarian tumors for histologic
Okay.
examination.
Okay, but then would you not want to do some other investigation to rule out or try to rule out malignancy?
We can look for blood biomarkers. CA-125 more than 35 units per liter is uh, suggestive of ovarian malignancies.
Okay, at this gestational, I mean, at this age, 35 years of age, would you think that CA-125 is going to be of much use?
Oh no.
Why not?
So not sure about that.
Okay, so in young patients, whenever they menstruate, your CA-125 increases. Apart from that, whenever a patient has an episode of PID, your CA-125 increases. Your CA-125 is an epithelial marker, and your epithelium is present all over your abdomen and in your pelvis. So whenever there is anything related to your peritoneum or anything related to any epithelium in your abdomen, your CA-125 increases, which is why in young patients who may have endometriosis, who may have menstruation, the levels are going to be falsely high. So usually we do epithelial markers or epithelial tumors that we see from CA-125, that is serous and mucinous carcinomas. They are going to be seen in the post-menopausal age preferably. And in a younger female, what are the types of tumors that you would probably see?
So we might the ovarian tumors that might be possible in a younger female could be serous as well as mucinous cystadenocarcinomas.
Okay, I literally just said that they are more common in the perimenopausal and postmenopausal age group. Something much more commoner in younger females.
So malignant dermoids could be there. Dermoid cyst.
Okay, what does it fall under? Which class of tumors?
Germ cell tumors.
Germ cell tumors.
Germ cell tumors. Great. So, what are the various germ cell tumors that you know of?
So there could be sex cord stromal tumors. Uh,
Okay, sex cord stromal tumors are actually completely different class. Germ cell
Germ cell
tumors are not that.
include teratoma, which can be again benign or malignant. Then
Okay,
can be a variant of seminoma in females, which is dysgerminoma, and there
okay.
can
What
be
is the tumor marker for that?
uh, the alpha fetoprotein.
No,
Inhibin.
it is it is LDH, a non-specific marker, but LDH is the marker for dysgerminoma. Okay, what else?
Then there can be choriocarcinoma and yolk sac tumors.
Okay, a better way to call it is non-gestational choriocarcinoma, which is not associated with a molar pregnancy or non-gestational choriocarcinoma. Beta HCG is a tumor marker and yolk sac tumor, right? So yolk sac tumor is what is going to cause an increase in alpha fetoprotein. Okay. What is the other name for yolk sac tumor?
Endodermal sinus tumor.
Okay, correct. So once you are done with this, what is the next thing that you would do? USG is one thing, but is there anything better that you can do?
Uh, So imaging studies can be done using MRI, CT scan, as well as X-rays.
Correct. So what do you wish to see that you are not able to see on ultrasound?
Uh, so on MRI, soft tissue masses are seen, metastasis are seen.
Okay, one more important thing, very important thing that you see on CT and MRI that you don't see on USG.
Septations are present or not in the tumor.
That can be seen on USG. You are going to be trying to seeing the lymph node involvement. So paraiotic lymph nodes देखने में help होगा so that we know till what extent has it spread. So that is very important. And that is what is going to be done by a CT scan, CT angio especially, CECT as well. So a PET CT can also be done if you want to look for metastasis. Okay. What is the surgery that you do for an ovarian mass called as?
Sir, we have to do oophorectomy, but along with that, we also have to do a salpingo oophorectomy, like the fallopian tubes also have to be removed.
Is that the procedure of choice that you do for benign tumors? Oophorectomy?
Benign tumors.
So for benign tumors, you would preferably want to do that because this is a young female, 35-year-old female, you cannot afford to get her ovary removed. So you have to try to do for a benign tumor just cystectomy. If it doesn't happen or if the ovary is not getting separated, then you go ahead with the salpingo-oophorectomy. Is there any reason why you also do salpingectomy along with oophorectomy in these patients?
So according to the
Sorry.
basic theory of carcinogenesis, the tumor arises from the fimbrial ends or the fallopian tube. So it's called the distal fallopian tube carcinogenesis theory.
Correct. Excellent answer. So which tumor does commonly arise from there?
Epithelial tumors.
Epithelial, more specifically a serous epithelial tumor.
Epithelial.
Okay, and what is the surgery that you do for a malignant mass?
Sorry, we couldn't hear you.
What is the surgery that you do for a malignant mass?
Sir, total abdominal hysterectomy with bilateral salpingo-oophorectomy.
No, the answer is staging laparotomy. Staging laparotomy is what you do for them. Okay.
Yes.
So yeah, so staging laparotomy is going to be done wherein you open the abdomen and every single layer that you see, be it your peritoneum, be it your pelvis, be it your diaphragm, every single layer, omentum, infracoelic omentectomy is done. You would be taking a biopsy and specimen of everything. You'll be sending peritoneal collection, जो भी fluid है उसका cytology भेजोगे. Every single thing is done, and intraoperatively you will be giving a stage to that patient as to how spread out it is. You would also be trying to feel the para-aortic lymph nodes with your hands, and if they feel matted or if they feel enlarged, you will be trying to do, and you will definitely do a para-aortic lymphadenectomy as well. So it is called a staging laparotomy because with every step you are going to upstage the tumor. You are going to try to stage the tumor. You are going to know up to what extent has the tumor spread in the pelvis and in the abdomen. So this is staging laparotomy, and after that you would be giving them a dose of chemo or radiation if that tumor that comes on histopathology and immunohistochemistry is sensitive to that specific chemotherapy. So that is it from all the four cases. Well done, Vineet. But then both of you, I've personally had you in KM, and I certainly expected a little more from both of you. But well done, nevertheless. Thank you, Vineet. Thank you, Sumedh.
Thank you, sir.
Thank you, Sumedh. Yeah. So next team, Mohak and Srilekha, Darshan and Mohit. Which one of you would want to present up next?
Sir, we would like to go.
कौन बोला रे? दर्शन बोला क्या?
अच्छा.
Okay, fine. Before that, before we proceed, has everyone understood everything in the audience? There are a few doubts. I'd be answering them towards the end. Are you all enjoying the pattern? I know it's a little too quick, but then unfortunately there are so many cases, and I of course cannot go on throughout the night. I have to just give 5-10 minutes per case. But I hope you all are understanding the main part of it. Whatever doubts you all have, please let me know in the chat. So okay, so we'll start with your cases, Mohak, right? Yeah. Okay. Okay. So Mohak, starting with your cases first. Should we begin? It's 10:23 right now, so your cases will go on up to around 10:55, 11. Okay? ये किसका
Yes.
डिस्टर्बेंस आ रहा है इतना तेजी से? तुम लोग का ही है क्या बैकग्राउंड?
Someone's mic is on.
Someone's mic is on. Alekya, could organizers could you just please put off Alekya? Her voice is I am not able to mute her. Please mute Alekya. अरे मेरे को मत म्यूट करो रे, Alekya को करो.
I muted all because I was not able to find the person.
अच्छा,
So
ओके
that's
ओके
why.
ओके. मोहक का ओके, ये लोग का है ना, ठीक है चलेगा.
Yes, sir.
Fine.
Sir, am I audible?
Yeah, you are audible. Srilekha is
Okay.
also with you, right?
Yes, sir.
Okay, fine. So your first case, your time begins now. You'll have 35 minutes approximately. So your first case is it's a 55-year-old female, para for living for. Please excuse my background voice, I can't help it. Tubal ligation done. She came to you with complaints of pain in abdomen. something coming out per vaginal since 5 years. She has no urinary complaint. She's postmenopausal since 5 years. On examination, her obstetric history, in fact, is suggestive of para-4 living 4 and all are home deliveries, and they are all home deliveries. That is very important here. On examination, her per abdominal examination is soft. Per speculum examination shows grade 3 uterine prolapse. Cystocele is also there, ectocele is also there, and the perineum is also appearing deficient. So the perineal body is absent, it is deficient, it is lax. Per vaginal examination shows that the uterus is retroverted of normal size and bilateral fornices are free. Mohak, Srilekha,
Yes,
how would you proceed?
yes. Sir, so basically this seems to be a case of pelvic organ prolapse, sir. Sir, in the history, there are like many things. Firstly, she's a 55-year-old female. As she is in menopause, and we know that estrogen कम रहता है menopause में. So the endopelvic fascia which supports the uterus and all the other pelvic organs, it has estrogen receptors. And the ligaments also, which are basically the condensation of the endopelvic fascia, they also have estrogen receptors. So with menopause, estrogen reduces, and the basically the supports they get less strength, मतलब वो weak हो जाते हैं, and it leads to prolapse. Secondly, she is a P4L4. That is, she's a multi-parity female. She has undergone many deliveries. So with deliveries क्या होता है कि abdomen मतलब जो supports रहते हैं, they become lax and they become weak, which can also cause the pelvic organs to prolapse.
And also there are home deliveries.
And there are home deliveries. So home deliveries में sir untrained लोग रहते हैं, and what they do is they do early bearing. So basically what happens is that early bearing is when we give abdominal pressure against a not fully dilated cervix. So वो pressure की वजह से the paracervical जो fascia रहता है, it becomes weak. There are tears in it and it becomes weak, and the female is not able to recover from it. Especially in home deliveries, that she does not have the मतलब उसको बोला नहीं जाता है to do the Kegel exercises.
And
So
also she
that
will
is also
go back to her strenuous exercise quicker if she's not advised by her
Yes.
home care too.
अरे मस्त आंसर दे दिया, एक नंबर. So, okay. How would you grade the prolapse then? What are the various ways of grading your prolapse?
Sir, basically there are many grades. पहले Jeffcott आया था. Then there was Shaw's classification, Malpass, but now sir we follow the POCU classification, that is pelvic organ prolapse quantification classification. In this sir, the hymen is the point, and basically there are 5 grades. Grade 0 matlab prolapse is not there. Grade 1 matlab it is above 1 centimeter from the hymen. Grade 2 is when it is 1 centimeter from the hymen to 1 centimeter below the hymen. Grade 3 is when it is 1 centimeter below the hymen to total vaginal length -2, and when it is more than total vaginal length -2, पूरा नीचे आ जाता है, प्रोसीडेंशिया हो जाता है, and it's grade 4 sir.
क्या बात है, ये पीजी लोग को भी आंसर नहीं आता है थर्ड ईयर खत्म होने होता है. वेरी गुड. ओके, फॉर दिस पेशेंट व्हाट इज गोइंग टू बी योर मैनेजमेंट?
Sir, as her family is complete and already tubal ligation is done. So we would like to do vaginal hysterectomy, and for correcting the cystocele and rectocele, we will have to do pelvic floor repair, which is anterior colporrhaphy and posterior colpoperineorrhaphy. And while doing vaginal hysterectomy, we will also do uterosacral suspension to prevent future vault prolapse, and Meckel's cultoplasty to prevent future enterocyte.
And sir, ये total vaginal hysterectomy और जो perineal floor repair है, इसका मतलब they are together known as ward neo surgery. So sir, we'll go for the surgical approach as Srilekha mentioned, only after considering if the female does not have any other comorbidities which can constrain her from undergoing a surgery. If she has any other comorbidities, then sir, हम लोग we can go for the
ring pessary or
ring pessary, yes sir.
colpocrisis, depending on कितने comorbidities हैं.
बाप रे, 7 करोड़ रुपए. What an answer. Excellent answer. Yeah, there is literally, I'm searching for questions. I've rarely found myself in this spot in this chapter. I'm literally searching for questions, but that's an excellent answer. I'll just make it a little more tough for you. You have a 90-year-old, same everything, but she's now a 90-year-old female, and she has history of 2 to 3 myocardial infarctions in the past. And just like Bhishma, she has gotten Vardhan ki wo jeene wali 100 ke umr tak. So, but she is highly comorbid. What would be your surgery for her?
Sir,
Sir, first we will treat the comorbidities, like if she has diabetes mellitus or hypertension.
अरे वो तो ठीक होने से रहा, अभी 90 ईयर में क्या तू कोमॉप्स ठीक करेगी? उसको हार्ट डिजीज है, वो जाने वाली है. but उसका prolapse उसको तकलीफ दे रहा है,
Sir, ring
and she
pessary,
doesn't want a pessary.
ring pessary
She doesn't
दीजिएगा,
want
sir.
a pessary. You cannot give a pessary for anything that is grade 3. You can only give it for grade 1 and 2 because तेरा base ही अगर नीचे आ गया तो वो pessary कहाँ
Sir,
रहेगा?
then we can go for Lefort colpoclysis, sir.
Excellent
Uh,
answer. That is the answer that I'm
Sir,
looking for.
Lefort
Left foot
colpoclysis में basically क्या करते हैं? We cut the cervix. We
stitch the anterior.
हाँ, we stitch the anterior and the posterior wall of the vagina, sir. But only after we have ruled out endometrial carcinoma by taking an endometrial biopsy. क्योंकि अगर हमने बंद कर दिया and carcinoma रहा सर, तो फिर वो blood accumulate होकर endometriosis वगैरह सर बहुत मतलब हो जाएगा फिर उसका.
क्या बात है, excellent. The people who give the best answers in OBGY are actually the ones who will never take up OBGY in their residency. Excellent answers, great answer. I have absolutely nothing more that I would want to ask in this. So great answers, very good. We'll move on to the next question. So the next question is, it's an 18-year-old female, she's unmarried. I'm audible, right?
Yes.
Yes, sir. Yes.
Yeah. So she has not yet attained menarche. On examination, her BMI is 20, a little on the leaner side. Her breasts are of Tanner stage 5. Axillary and pubic hair are present. Her abdominal examination is soft. There's a blind vagina, unfortunately, and her external genitalia is well developed. Her uterus is not palpable. What's your differential? How do you proceed?
Sir,
Be careful
please.
when I say how do you proceed. I want to know every single approach for this female because she has her entire life lying ahead of her, including her marriage. Tell me.
Sir, first differential for this is MRKH, and second differential
is AIS, sir. Because karyotyping mention नहीं किया है सर. अगर karyotyping mention करते और XS रहता तो सर MRKH रहता, Mullerian agenesis.
AIS तेरे को लगता है क्या? AIS में तेरा
Mullerian agenesis सर.
तूने
Mullerian
AIS
agenesis
बोला
is
ना?
नहीं सर, Mullerian agenesis हमारा फर्स्ट है, बट
नहीं नहीं
AIS
नहीं,
सर.
तेरा सेकंड डिफरेंशियल तूने क्या बोला? AIS बोला ना?
yes, sir.
AIS तेरे को लग रहा है एक्सिलरी एंड प्यूबिक हेयर प्लस में?
नहीं,
सर
sir,
एक्सिलरी एंड
scanty.
प्यूबिक हेयर स्कैंटी रहता है, वी नो सर, बट वो दो डिफरेंशियल्स रहते हैं सर एक साथ. दैट्स व्हाई वी आर टेलिंग सर. और
So
इधर
you would rather
karyotyping
want to say partial androgen insensitivity,
Yes, sir.
PAIS. Yeah,
yes sir.
Yes.
correct. ठीक है, continue.
Sir, so first we will do karyotyping because
हाँ.
हमको 36 XX 46.
Karyotyping, great answer. Do you think karyotyping is going to be affected in this patient?
No
The
sir.
patient is a very poor patient. Every single test is going to cost her a bomb. Would you want to do
Yes.
karyotyping? What do you
Sir,
want to look for?
we want to basically differentiate between MRKH and AIS, partial AIS. So इस केस में पहले we will confirm कि uterus is actually not present क्या, तो we will do USG.
Okay,
And
that's a
then-
good answer. In fact, yeah, that's a good answer. So karyotyping, तूने actually karyotyping का answer justify कर दिया. That's a good answer. Anything more than karyotyping that if the patient is wealthy enough that you would want to do? Genetic testing?
Genetic testing. Sir, sorry sir, we don't know.
It's okay, no problem. That's a higher level thing. No problem. That's fine. Proceed. Proceed with your question. With your answer.
So sir,
So we will first do an USG to look for uterus. अगर इस पे भी uterus नहीं मिला, then we can go on with MRI or 3D USG just to confirm the diagnosis. And if uterus is absent, like if it is confirmed that uterus is absent, then it is most likely because of bilateral Mullerian duct agenesis.
that is MRKH, sir.
Okay, correct.
And also
What
we will
if it
also do
shows a hypoplastic uterus with small amount of endometrium?
Sir, hypoplastic uterus, sir, it can be Turner syndrome, sir. But axillary hair वगैरह है
हाँ?
breast
क्या?
तो सर
क्या
नहीं
बोला?
होएगा सर. सर नहीं होएगा टर्नर सिंड्रोम क्योंकि एक्सिलरी हेयर और प्यूबिक हेयर है एंड ब्रेस्ट मतलब टर्नर स्टेज 5 पे है तो नहीं रहेगा टर्नर सिंड्रोम.
Axillary hair, pubic hair तो turners में भी रहेगा, but तेरा breast का development नहीं होगा. Very good. Okay. So what if it's a hypoplastic uterus? How does your management change? पहले तो मेरे को पूरा MRKH का ही management बता दे कैसे करेगा.
सर अगर हाइपोप्लास्टिक यूट्रस है तो सर वो डायथाइल स्टिल्बेस्ट्रॉल का ये रह सकता है क्या सर?
No, उससे T-shaped uterus आएगा cavity. This is just a hypoplastic uterus with small endometrium, small amounts of endometrium that are present in it. How would you proceed? पहले मेरे को MRKH बता when there is absolute absence of uterus and fallopian tubes and cervix. How would you manage? Also blind vagina.
Sir, so first we will do vaginoplasty so that she can like
When?
just before or after her marriage.
Correct. Great
So
answer.
sir, she
Why?
can have coitus and sir we can ask her if she wants to have children, sir we can go for IVF via surrogacy, sir.
Surrogacy.
Okay, great.
Because her ovaries are normal, sir. So she will
Okay,
be
so what she can
ovulating.
do is, okay, correct. So she can give oocyte donation and
Yes.
through surrogacy. Surrogacy is the answer at IVF. Correct answer. Okay, great. So you have spoken about the fertility. You have spoken about the sexual life, coital life. Okay, what are the procedures that you do for vaginoplasty?
Sir, there is McIndoe's procedures and Visiti's procedures there. Visiti is done trans-abdominally, sir.
Sorry, could you just repeat your answer? I couldn't hear you.
Sir, there is McIndoe's and there is Vichetti's. Vichetti's is
Correct
done.
answer.
Vichetti's is done trans-abdominally.
Okay, very good answer. Do you know of any other procedure apart from these two?
No, sir.
Davidoff procedure. So that's a great answer. Okay, no problem. Even if you know these two procedures, that is good enough. So the point of doing a vaginoplasty is we have to increase the vaginal length so that she can at least have a good sexual post-married life. And hence you have to create a vagina of an optimal length. And now because she doesn't have vaginal tissue, you will be using other stem cells and there's other stem cells. What are the other things that you can use potentially for stem cells? Anything that you can answer? We do use it at KEM.
No idea, sir.
Sorry, sir, we
Sir,
don't know.
rectus.
Think
No,
about
sir.
it. Thoda sa. In fact, I'll give you a hint. If you have ever attended the obstetric OT, the plastic surgery ka team always comes for elective LSCS. Why do they come for elective LSCS? उनका क्या लेना देना है?
So could you please repeat your question, sir? मतलब सुना नहीं था ठीक से.
Whenever you are having an elective LSCS that is going on in our own obstetric OT, हमेशा प्लास्टिक सर्जरी का टीम आता है ओटी में. क्यों आता है वो? उनका काम यही है लेना. क्या ऐसा चीज लेते हैं वो हम लोग से?
No idea, sir.
So your amnion will contain, yeah, so your amnion will contain stem cells. So you can use your amnion graft or amniotic graft for doing your vaginoplasty. Apart from that, you can also use your own peritoneum. Your peritoneum will also contain stem cells and it is also extensive. बहुत ज़्यादा quantity है मेरे पास peritoneum. So I can use the peritoneum as well and I can do these procedures. Okay. One thing that will need to be ensured after the surgery, कुछ करना पड़ता है to ensure that it doesn't again have strictures in it?
सर हम लोग
Immediately post procedure.
सर vaginal bogies डाल सकते हैं सर या cotton swabs डाल सकते हैं for something.
Correct. So vaginal dilators are going to be inserted to ensure that it is patent or at least she has to maintain a regular coital life. Great answer. Excellent answer. Hypoplastic uterus रहेगा तो क्या करोगे?
Sir, no idea, sir.
Don't worry, no problem. That's enough for you. Excellent answer, nevertheless. Great answers. Fine. So MRKH is your first diagnosis. MRKH में कुछ नहीं कर सकते. There have been a few surgeons who have attempted uterine transplant, but they have not been able to do it. So that is out of question for now. At some point, though, there will be people who will be doing it. But at this point, you can do nothing about it. Apart from that, it is just counseling and ensuring that she gets done with a vaginoplasty just prior to her marriage. What if this would have been AIS? क्या करता तू? एक और चीज कुछ देखना चाहता तू AIS के पेशेंट में?
सर AIS में क्या हो रहा है कि बेसिकली जो टेस्टीज है दे आर रिलीजिंग टेस्टोस्टेरॉन. इट्स एक्चुअली अ मेल and testes are functional, they are releasing testosterone, but the testosterone is not able to bind to the receptors. So at puberty, testosterone gets converted to estrogen and that's why the breasts are developed. So we will have to do gonadectomy to prevent malignancy, but we will do this after the breasts are developed.
Excellent answer. Brilliant answer. Must answer दे दिया. वाह. Next question. There is absolutely nothing more that I can ask here. Great answer. So next case. 28-year-old female who has come to the gynae OPD with secondary infert. LMP is 7 days back. She has 1 to 2 cycles every 30 to 45 days, slightly irregular. Obstetric history, she is married since 6 years, previous to abortion, 2 months of amenorrhea for which she underwent DNC. She is a known case of hypothyroidism on treatment. She is also lean and thin. Her pulse, BP, everything is normal. CVS RS is also normal. Per abdominal, normal examination, per speculum, per vaginal, everything normal. How do you proceed? Secondary infert.
Sir, basically, with the history, sir, we are coming to know that there have been previous 2 abortions with dilatation and curettage, sir. So अगर dilatation and curettage किया है and there is secondary infertility, then sir there can be it can be a case of Asherman syndrome.
Okay,
And
correct.
also sir there is a history of hypothyroidism. So as mentioned earlier that hypothyroidism will cause GnRH activation and वो pulse frequency में it won't GnRH won't be reduced in pulses. So anovulation हो जाएगा sir, and that can also cause secondary infertility. So hypothyroidism can also be one cause, sir. Hello. Hello. Hello.
Hello, sorry, my voice was off. Yeah, so just before we proceed, SIMSOG has put up a link in the comments wherein we have stored surgeries of vaginal agenesis and for MRKs. There are live videos. I would love if you all could watch it after the session, and please save that video link. That's a great video. Okay, so coming back to your Viva, known case of hypothyroidism hai. Just coming a bit towards hypothyroidism, if your patient is going to conceive, what do you do about hypothyroidism? About the dose of levothyroxine that she's taking?
Sir,
We start at a low dose. We start at 12.5 mg microgram per day.
Are you sure it's
And then
12.5? That is in fact one of my
12.5 at
biggest.
25, sir.
What is
Sir,
the
basic,
dose? What is the dose that we give?
sir, अभी dose तो sir we don't remember, but mostly we start with 12.5, 25 or 50,
Very
and then
simple.
we
1
increase.
microgram per kg is the dose. इतना
Okay.
सिंपल है, सिर्फ 1 माइक्रोग्राम पर केजी, एंड किसी औरत का वजन 12 किलो तो रहेगा नहीं. सो बेयर मिनिमम जो हम देते हैं वो है 37.5 या फिर 50 माइक्रोग्राम, क्योंकि मोस्ट वुमेन आर अराउंड द वेट ग्रुप ऑफ 50 केजीज एंड बियॉन्ड. So that's it. If your patient was already a known case of hypothyroidism and she's already taking levothyroxine, what is the change that you do to her dose in pregnancy?
Sir, pregnancy में will increase the dose, sir,
How
because
much?
there will be hemodilution, so increase करना पड़ेगा for proper action.
so
Is it for
we have-
hemodilution or is it for something else?
so we have to make sure that the TSH levels are less than 2.5.
Okay, correct. But then what is the dose? How much of step up would you do?
No idea.
Okay, so you'll step it up by 25 microgram or you would double the dose on weekends. Okay. Hypothyroidism, okay. In your case, what are the investigations that you would want to do?
So first we will do the thyroid profile to check that if she is optimally being treated for hypothyroidism.
Okay.
And sir, thyroid के साथ भी also
Prolactin levels also
Correct. Prolactin levels, yes. What else?
And also because we said earlier that we are suspecting Asherman syndrome because there is two histories of DNE. So we will
Okay.
also do
First we'll do a transvaginal ultrasound
and
and
then we can do
hysteroscopy.
hysteroscopy
And-
is diagnostic and therapeutic, but for screening we can do HSG. So
And
if
so we can
see
also
filling defects on
filling more
HSG.
titan appearance taking on HSG, then it will be a diagnosis of, then it can be a diagnosis of DNE. We can also do estrogen and progesterone challenge test, sir. In that, when there will be no bleeding, it will point towards Asherman syndrome.
Okay, correct. What else? What other investigations apart from Asherman's and endocrinological disorders that you would want to look for? What are the various types of infertility that you have in a female? What are the various factor infertilities?
So there is ovarian factors, there are tubal
Okay, how do you
factors.
test for ovarian factor?
We have to look for ovulation and we have to also look for the follicles. Like if there is premature ovarian insufficiency, we have to rule out that.
If she's more than
Okay,
35
how
years.
do you look for ovulation? What are the tests of ovulation?
So for ovulation,
The
we
best
can
test that we do is
serum
serum progesterone
progesterone.
levels. That is done on day 21, 22 of the cycle because
Okay, okay.
then progesterone levels are maximum.
If it is less than 3, sir, that means in 3 nanogram, then that means that the ovulation has not taken place. Then, sir, we can also do tests like basal body temperature, in which there will be 0.5 to 0.8 degree Fahrenheit increase in the temperature. And we'll check the oral temperature in the morning of the woman before she has anything or like water or anything. And we can also do vaginal studies, sir, to check for the superficial cell, intermediate cells, and the parabasal cells. Sir,
There is maturation index and
there is one maturation index and karyopnotic index. So in sir, if ovulation has taken place, progesterone will be on the rise and there will be more number of intermediate cells. And if it has not taken place, then estrogen will be on the rise and there will be more number of superficial cells, sir.
and also cervical
Mucus studies कर सकते हैं, sir. So in cervical mucus studies, if estrogen is more, there if ovulation has not taken place, estrogen is more and then it is thin and profuse, the mucus. So वो spin bar की test रहेगा where it will be stretchable more than 10 centimeter in length. And अगर patient ने किया तो उसको Billings test बोलते हैं. And अगर वो thick रहा, then ovulation हो चुका होएगा. एंड सर इसका एक इंसुलर स्कोरिंग रहता है, तो इंसुलर स्कोरिंग से वी सी द कैरेक्टरिस्टिक्स ऑफ द म्यूकस प्लग एंड वी सी वेदर ओवुलेशन हैज टेकन प्लेस और नॉट.
अरे बाप रे, क्या आंसर दिया है, खतरनाक आंसर दिया है, टू गुड यार. ओके, सो दिस इज फॉर योर ओव्यूलेशन. Apart from ovulation, how do you look for uterine and fallopian tube? You would be doing an HSG, that is enough. Anything that you have missed until now in your entire case? एक फैक्टर तूने देखा ही नहीं है बिल्कुल.
सर्वाइकल फैक्टर्स हो सकते हैं,
हम्म,
लाइक
हम्म.
सर
इन दिस केस
सबसे इम्पोर्टेंट चीज भूलने का नहीं है.
सर इरेगुलर पेनलेस है
नो,
सर.
ऐसे सेक्सिस्ट मत बनो.
सॉरी सर.
ऐसे सेक्सिस्ट बनो मत.
नहीं सर.
अरे तेरा हिंट था ये.
थिन थिन विल है सर.
अरे सेक्सिस्ट बनो मत का मतलब है व्हाई वुडंट यू वांट टू चेक.
मेल पार्टनर के हम लोग इनफर्टिलिटी स्टडीज करेंगे सर. मेल इनफर्टिलिटी. यस सर.
एग्जैक्टली. अरे मेल फैक्टर इज 30% ऑफ द केसेस. तेरा फीमेल इधर सब नॉर्मल निकलेगा और मेल में कुछ तो प्रॉब्लम निकलेगा. फीमेल को टेस्ट करते जा रहा है, इंडक्शन ओव्यूलेशन इंडक्शन सब दे रहा है और मेल का इशू आ रहा है. ठीक है, तो मेल में क्या क्या करेगा?
सर मेल में सर बेसिकली देयर विल बी प्री टेस्टिकुलर कॉजेस, टेस्टिकुलर कॉजेस एंड पोस्ट टेस्टिकुलर कॉजेस. सो प्री टेस्टिकुलर
we will do the semen analysis. तो उसमें we have to do 2 to 7 days के abstinence के बाद we have to do semen analysis. 2 days से पहले कम abstinence पे किया तो there would be false reduced sperm count, and 7 days से ज्यादा abstinence हुआ तो there would be false increase in dead sperms.
तो अगर azoosperm में आया सर, अगर azoosperm में आया, so we'll again do the semen analysis after 2 to 3 weeks. And sir again अगर azoosperm में आया, then we'll do the hormonal level sir. तो अगर FSH LH बढ़ा हुआ है एंड टेस्टोस्टेरोन कम है, then it will be hypergonadotropic hypogonadism which points towards testicular causes. Then अगर तीनों like Klinefelters और mumps और orchitis और if there is any occupational,
मतलब अगर high temperature और tight garments.
फिर सर अगर FSH LH and testosterone all are less, then it will be hypogonadotropic hypogonadism which can be either a pituitary cause or a hypothalamic cause. Like there can be an infiltration of an infection or TB meningitis वगैरह हो सकता है उसको. एंड अगर नॉर्मोगोनाडोट्रोपिक नॉर्मोगोनाडिज्म मतलब सब कुछ नॉर्मल है, देन इट विल बी अ पोस्ट टेस्टिकुलर कॉज सर, लाइक रेट्रोग्रेड इजैकुलेशन हो सकता है, और देयर कैन बी अ ऑब्स्ट्रक्टेड इजैकुलेटरी डक्ट या सिस्टिक फाइब्रोसिस इन व्हिच देयर इज अ बायलैटरल कंजेनिटल एब्सेंस ऑफ सेमिनल वेसिकल सर. सो वी विल इवैल्यूएट फॉर ऑल दोस सर. देन
और अगर obstruction आया so then we have to see the semen volume and also the fructose. So if fructose is present, as fructose is secreted by seminal vesicles, मतलब the obstruction is above the seminal.
तो एपिडिडाइमस या रैश डिफरेंस में है, बट अगर फ्रक्टोज और ये कम है, फ्रक्टोज और सीमेन कम है, देन सर हम लोग ट्रांसरेक्टल करते हैं यूएसजी टू चेक फॉर सेमिनल वेसिकल. अगर वो एब्सेंट है तो सिस्टिक फाइब्रोसिस है, अगर प्रेजेंट है और डायलेटेड है तो एपिडिडाइमल ऑब्स्ट्रक्शन है, बट अगर प्रेजेंट है और डायलेटेड नहीं है तो रेट्रोग्रेड इजैकुलेशन है व्हिच कैन बी व्हिच कैन बी ड्यू टू न्यूरल कॉजेस लाइक ये अपना स्पाइनल शॉक वगैरह की वजह से हो सकता है सर. मतलब बेसिकली न्यूरल कॉजेस सर, एमएस स्पाइनल शॉक वगैरह की वजह से रेट्रोग्रेड इजैकुलेशन हो सकता है सर.
खतरनाक यार. बस कर रुला देगा तू. टू गुड. इट कुडंट हैव बीन एनी बेटर. पूरा मेरे को ही सिखा दिया इनफर्टिलिटी. एक्सीलेंट. आई एम जस्ट गोइंग ऑन. एंड हाउ डू यू जस्ट मैनेज दिस पेशेंट? टेल मी क्विकली. एक आंसर मेरे को बता दे. इन दिस केस तेरे को लग रहा है एशरमैन है, कैसा मैनेज करेगा?
So Asherman में sir, as mentioned earlier, we'll do hysteroscopic adhesiolysis and pediatric Foley's catheter insertion करेंगे with saline, and we'll give estrogen and progesterone for 3 months so that the endometrial lining is built up, and stem cell कर सकते हैं हम लोग if there is thin endometrium. And for hypothyroidism, we can continue with the मतलब if she has not started, we can start with thyroxine sir.
और अगर treatment optimum नहीं है तो फिर
Increase the dose sir accordingly. And अगर
Okay,
मेल
correct.
इनफर्टिलिटी है, then we'll check for the male infertility and we'll do that thing also, मतलब उसका भी ट्रीटमेंट कर देंगे.
Okay, correct. Very good answer. I'm just not going to be persisting on this topic. You have answered it really, really well. Great answers. Going on to the next case. 55-year-old, para4 living for TL done. You have
Yeah.
अच्छा खासा 11 minutes with you. TL done. Complaints of something coming out per vaginally since 5 years. Incontinence. I'm audible, right?
Yes.
Yeah, incontinence of urine with cough. So stress incontinence तो लग ही रहा है. Postmenopausal since 5 years. Para 4 living 4, all 4 again home deliveries. She also has on speculum examination third degree uterine prolapse, cystocele, rectocele, deficient perineum, but right now her Boni's test is positive. Her uterus is retroverted, normal size, bilateral fauna history. How do you proceed?
Sir, so basically this is a case of uterovaginal prolapse with stress urinary incontinence because the Boni's test is positive. So sir, basically stress urinary incontinence के three theories है. सर सबसे पहले intrinsic theory है, then integral theory है, and then Hammock theory है. तो intrinsic theory में क्या होता है सर, जो यूरोथीलियम है उसमें deficiency होने की वजह से जो यूरिन रहता है मतलब उसमें ब्रेक्स हो जाते हैं ड्यू टू विच देयर हाइपर मोबिलिटी ऑफ द ये एंड क्लोजिंग प्रेशर कम हो जाता है सर यूरेथ्रा का, जिसकी वजह से कॉफ करने पे भी या abdominal प्रेशर बढ़ने पे भी देयर इज स्ट्रेस यूरिनरी इनकॉन्टिनेंस. Then, sir, there is a integral theory in which the same as uterovaginal prolapse की endopelvic fascia ही कम हो जाता है जिसकी वजह से hyper mobility हो जाता है. And then there is a Hammock's theory. तो Hammock's theory में क्या होता है कि जो the anterior wall of the vagina, it acts as a hammock for the urethra. So it prevents the hypermobility, sir. So these are the three theories. Yes, sir. And sir, फिर Boni's test for the diagnosis of this. Hello.
हाँ हाँ सुन रहा हूँ, मैं तो बोलते जा, मैं सब सुन रहा हूँ.
हाँ sir. Sir, so on मतलब first when we take the history, sir, we ask the woman did she have any stress factors like chronic cough or constipation, or she having a low fiber diet जिसकी वजह से उसको constipation हो रहा है. Then sir, we ask for urge and frequency symptoms. Then we ask for dysuria, fever for UTI to rule out urge incontinence. And sir, we can also ask for drug history like anticholinergics अगर वो ले रही है. So sir, anticholinergics like in the case of antispasmodics या ये अगर पार्किंसंस की ड्रग्स ले रही है तो सर एंटीकोलिनर्जिक्स की वजह से जो यूरेथ्रा है वो रिलैक्स होके सर इनकॉन्टिनेंस हो जाएगा. ऑल्सो सर अगर शी इज टेकिंग सेडेटिव्स तो सेडेटिव्स में वो भूल जाएगी दैट शी हैज टू मतलब शी विल गो टू स्लीप एंड बेसिकली शी विल फॉरगेट दैट शी हैज टू यूरिनेट. तो वो ओवरफिल इनकॉन्टिनेंस होने की वजह से सर प्रेशर नेक्रोसिस की वजह से इट कैन टर्न इनटू अर्ज इनकॉन्टिनेंस. सो वी विल रूल दैट आउट आल्सो. देन सर टेस्ट्स के लिए वी विल ask her for sir test के लिए we'll do Boni's test.
Sir, and on
टेस्ट का बात कर रहे
examination,
हैं. Would you want to do a urodynamic study for her?
Yes sir, यूरोडायनामिक स्टडीज हम लोग सबके लिए करते हैं सर. सर सो
क्यों
इन यूरो सॉरी सर
क्यों क्यों क्यों?
सर यूरोडायनामिक स्टडीज से सर वी कैन बेसिकली डिफरेंशिएट बिटवीन स्ट्रेस यूरिनरी इनकॉन्टिनेंस, अर्ज इनकॉन्टिनेंस एंड मिक्स्ड इनकॉन्टिनेंस. सर बेसिकली क्या होता है कि नॉर्मली स्ट्रेस यूरिनरी इनकॉन्टिनेंस में नहीं करते बट व्हेन अगर हमको करना ही है मतलब वी शुड डू इट बिकॉज सर मिक्स्ड भी हो सकता है. सो वो स्लाइटेस्ट पॉसिबिलिटी रहता है अर्ज
Just answer in
इनकॉन्टिनेंस का.
English. There are a few requests that you have to answer in English because there are a few students who are unable to understand Hindi. So just continue in
Sorry, sir.
English.
Sir, with stress urinary incontinence, there is also a slightest possibility, it is always there that there is a slightest possibility of urge incontinence. So to rule that out, sir, we'll do Europe study, sir.
Correct. So basically, every patient almost invariably has mixed incontinence, wherein
Yes,
there's
sir.
one predominant component and the other one is non-predominant. So there is mostly either stress plus thoda minor urge or majority of urge with thoda bahut of stress.
Yes, sir.
So although the books say that classically in your exams also you have to say this, that the books say that you do not have to do urodynamic studies for stress incontinence, but because practically most patients end up having urge incontinence, especially in India, wherein metabolic syndrome is very common, and metabolic syndrome is a predisposing factor for urge incontinence, is why you do urodynamic studies in all the patients in our country, irrespective of the type of incontinence that she has. Okay, now you've mentioned about all this. What is going to be your therapy for her? Imagine कर ले तेरे urodynamic पे आया कि she also has urge, she also has stress. How do you proceed?
Sir, basically for stress, sir, we can tell her, sir, first we'll tell her to lose weight. First we'll start with non-pharmacological therapy. And sir, if she has stress, urge urinary incontinence, we can go with medical management, sir. So in medical management, we can give her anticholinergics like sir, trospium and like there are non-selective like trospium and
No.
tolterodine,
You
which we
only give
don't use.
selective because
हाँ,
non-selective से
selective देते
Alzheimer
हैं.
होने
We
वाला
give
है.
selective like darifenacin and solifenacin.
Very good.
And sir, we can also give her alfuzosin to release the pressure, sir. And we can also give her botulinum toxin, sir. Onabotulinum A we can give her intravesical. Sir, we put it on 20 locations, and basically what it does is it reduces the action of acetylcholine. So, sir, there will be less urge to pass urine. But the problem of this is, sir, that there is hypersensitivity. The woman, she gets the bladder of the woman, it gets sensitized to the botulinum toxin. So, sir, with increasing time, we'll have to increase the frequency of giving botulinum toxin. So we'll have to give it like, now we give it, first we start with once a year, but then we'll have to, sir, give it regularly, sir. Then, sir, we can also ask her to maintain a bladder diary, sir, in which she can she can note all the times she is passing urine, and the amount of urine she is passing, and like if she's passing any
नहीं,
urine
करेक्ट करेक्ट,
in,
समझा समझा, गुड आंसर। मेरे को अभी सर्जिकल मैनेजमेंट भी बता दे, मेडिकल मैनेजमेंट
sir,
एकदम
in
परफेक्टली बताया।
surgical management, sir, for stress urinary incontinence, sir, we can do a pubo vaginal sling, in which we take a muslin tape, and we go through the pubis, the upper border of the pubis, and we wound around the urethra at the bladder neck, and sir, we remove it again. So, sir,
Is
it
that the
stabilizes.
procedure of choice? Is that the procedure of choice, or is there any other
Uh,
procedure that is better?
No, no, sir. It's not a procedure of choice. There is mid-urethral slings like TVOT and TOT. That is tension-free obturator and tension-free
Tension
tension-free
free
obturator
obturator,
tape. Obturator tape,
tension free vaginal tape, and
and
transobturator tape. So TVT and
transobturator.
TOT.
Yes, sir. So
Okay.
transobturator tape is better, sir, because the chances of causing vaginal injury in transobturator tape is less. Uh, then, sir, we can also do retropubic colpo suspension.
वजाइनल इंजुरी, अरे तो वजाना में तो वैसे भी इंसिजन देने वाली, यू आर
नहीं नहीं
एनीवे
सर,
गोइंग टू बी
bladder
गिविंग
injury,
इट।
sir, bladder
हाँ,
injury.
ब्लैडर इंजुरी, करेक्ट, या।
Sir,
ओके
retropubic colpo suspension can also be done. So in that
ओके,
there is Birch colpo suspension, in which we suspend the vagina from the iliopectineal ligament, and we can also
वजाना और
suspend
द यूरेथ्रा।
colpo suspension, sir. So we do the vagina, sir. We suspend the
Correct
vagina,
answer, excellent answer, because the name
and
itself is colpo suspension, so colpo is vagina. Okay,
sir, there
correct.
is also sir, there is also one more name, MCC March. I don't remember the name, sir.
MMK procedure,
Yes, sir.
Michelle Marchetti Kranz procedure.
Yes, sir.
Okay,
In that,
correct.
yes.
Okay, so that is it about stress incontinence. Apart from that, एक और चीज भूल रहा है हिस्ट्री में, तो उसको मैनेजमेंट सिर्फ तूने एसयूआई का बताया, और कुछ?
सर वो प्रोलैप्स का मैनेजमेंट, सो इसमें भी देयर इज शी इज 55 year old एंड हर फैमिली इज कंप्लीट, सो वी विल अगेन डू वजाइनल हिस्टेक्टमी और सिस्टोसील और रेक्टोसील के लिए एंटीरियर एंड पोस्टीरियर, एंटीरियर कॉल्पोग्राफी एंड पोस्टीरियर कॉल्पोपेरिनियोग्राफी, यूट्रोसेक्रल सस्पेंशन एंड मेकल्सकल्डोप्लास्टी।
Correct answer. Perfect. Now that you're doing a vaginal procedure, you would also want to preferably do TOT, TVT instead of a retropubic sling surgery or
Yes, sir.
colposuspension surgeries. Excellent answer. Brilliant, Viva. Loved your answer. Yes, you are कहाँ से पढ़ा यार?
सर आपके लेक्चर सीधे में।
अच्छा, okay. मैंने इस पे सिखाया नहीं, मैंने कब सिखाया? अच्छा, वो ऑनलाइन वाला, ओके, ठीक है। नहीं नहीं, great answers, great, lovely answers, amazing, well done. You have also finished on time, so that's even better. Brownie points. Very good, well done. So
थैंक यू
last
सो
team,
मच सर।
thank you. And so should we go on for the last team? The last team, are you all ready?
Yes, sir.
Okay, Darshan. So last team, last 4 questions of GynoScope. Before that, we have already posted source. अरे source क्या है? इसका source है Berek and Novak. पढ़ लो, best है. And Teeland, the best source for urogynecology. Okay, so the last 4 questions of this Gynoscope, and we'll be beginning it at 11 right now. Just give me 2 more minutes. But before that, we have already posted the feedback form link in the comments. Please do fill it. This is going to be the last feedback form link, and we would love hearing from you all as to how your experience has been over these 13 sessions. So please fill it. Do not skip this one. And of course, the certificates are going to be gradually rolled out for you all on your mail IDs. So going for the last case discussion, all the best, Darshan. All the best, Mohit. So coming to the last 4 cases. Should we begin, Darshan, Mohit? Darshan, Mohit, should we begin?
Yes, sir.
Okay, please excuse the background voice. There is a lot of celebration that is going out. I'll just begin reading the case. Okay, so it's a 50-year-old para 3 living 3 tubal ligation done, known case of diabetes mellitus and hypertension on treatment. Postmenopausal bleeding since 2 months, and she has been postmenopausal since 6 years. Her BMI is 32. She is obese, of course, and her cervix and vagina is healthy. She is bleeding. Uterus is bulky and bilateral fornices are free. What is your first biggest differential?
So the first biggest differential is endometrial hyperplasia, basically, because she's postmenopausal also, and the uterus is bulky in this case. And history of diabetes mellitus and hypertension is given, which is the risk factor for the
Correct, correct. Very
endometrial.
good. What are your next differentials? What are your next set of differentials?
Polyp can be one differential, then the endometrial cancer can also be a one differential.
Okay. What else? What else? What other differentials would you be talking about? I'm looking for a few more. Not in this case, but for postmenopausal bleeding. What are your different differentials at this point?
Cervical cancer will be differential if it is postmenopausal. Atrophic vaginitis.
Your voice is cracking, Darshan. We are not able to hear you. I think I should.
Atrophic vaginitis.
Oh, no, no. There's an your voice. Just
Hello,
a
I am.
moment. Just a. Yeah. Am I audible now? Am I audible?
Sir, are you audible?
Audible? Okay. So, could you tell me what are the differentials for postmenopausal bleeding?
Sir, first of all, for postmenopausal bleeding, biggest differential will be endometrial hyperplasia, endometrial carcinoma.
Okay.
Then polyp can be there, atrophic vaginitis can be there, ectropion can also be there sometimes, and cervical cancer, obviously.
Okay. What else? एक कुछ तो सबसे important cause miss कर रहा है.
Hello.
Hello. Am I audible?
Yes, sir. Yes, sir.
Yeah. So, what is that one biggest differential that you're missing out at this point? Hello.
Yes, sir.
Hello. Yeah, one important differential that you're missing out at this point of time. Audience, am I audible? Are my questions audible? I'm not sure if. Yeah, they are audible, right? Okay. So, Darshan, Mohit, one differential, one important differential.
Granulosa cell tumor of ovary.
No, no, no. Something about the vagina.
Sir, senile vaginitis.
Yes, correct. Senile vaginitis. It's a very important cause of senile endometritis and senile vulvovaginitis or atrophic vulvovaginitis. A very important cause of your postmenopausal bleeding. Okay. So, how do you treat this female? How do you manage her?
Sir, first of all, we'll have to do a transvaginal sonography in this case to look for the endometrial thickness. So if it is more than 4 mm, then we have to do endometrial biopsy. And if it is less than 4 mm, then we can give a dose of tranexamic acid and then re-evaluate if it continues. Then we will do the fractional curettage basically after that for evaluation of more evaluation to confirm the endometrial cancer presence.
In this day and age, do you do fractional curate or is there a better modality that you use?
Fractional curettage with hysteroscopy.
So correct, yeah. So you will be doing hysteroscopic curettage or fractional curettage. That's a better answer because now you can visualize every single thing inside the uterus and you can specifically take the biopsy of that particular place where you can see any organic mass. Okay. Okay, so if you think there is endometrial hyperplasia, how do you manage it? You have sent it for histopathological examination. What are the differentials that you expect on your histopathological report?
So first of all, the report can become normal. So then we have to give a normal treatment of for bleeding and transexamic.
What is normal? You cannot have a normal report. You can have either endometrial hyperplasia अगर आया है तो क्या उसमें क्या दो differentials हैं?
With ATP and without ATP.
Very good. So what do you do for without ATPA?
For risk of without ATPI is 1 to 3% for malignancy. So generally we give
Correct?
medical management. On medical management, we give progesterones. We can give continuous progesterone as well as cyclical progesterone, but continuous progesterones are well preferred. And in that also, Mirena is well preferred.
Okay. When do you call her back for re-evaluation?
After 6 months, sir.
Yes, after 6 months, you'll be calling her back. If there is a Mirena in situ, do you remove the Mirena or do you keep it in situ and take the sample?
Sir, we remove the Mirena and
Are you
re-put.
sure about it?
Yes.
Your
Actually,
Mirena is going to
we
cost
can
you around
uh,
4,000.
because it costs more, so we can keep the marina inside, and we can through hysteroscopy we can take the biopsy around the site basically without
Correct.
touching
So
the site.
basically, you wouldn't want to actually remove the Mirena because your Mirena is itself going to take 3 to 6 months for its action to start coming. So the action has just started occurring and you wouldn't want to remove it and waste the money that you've invested. Okay. So your report shows again without ATPA. How often do you call her back again?
6 months, same.
Yeah, again 6 months ke baad. Now, after she has come back after 6 months, it shows ATPA. What do you do next?
Sir, you can confirm the diagnosis by fractional curettage and that hysteroscopy, and then we can
अरे कंफर्म ही किया है तेरा हिस्टोपैथ का रिपोर्ट ही
काउंसिल
आया
फॉर
है कंफर्मेटरी
मींस हिस्टेरेक्टोमी के लिए काउंसिल करेंगे.
हिस्टेक्टमी के लिए काउंसिल करेगा बट हिस्टेक्टमी कौन सा वाला करेगा प्रेफर
टाइप 3 हिस्टेरेक्टोमी सर.
टाइप 3 रेडिकल हिस्टेक्टमी वर्डेंस करेगा फॉर अ सिंपल एंडोमेट्रियल हाइपोप्लेजिया
रेडिकल हिस्टेरेक्टोमी.
वर्डेंस में यूट्रोसेक्रल वो सब निकालने का रहता है यूरेटर वेटर को भी हिलाने का रहता है वुड यू वांट टू डू इट दैट एक्सटेंसिवली
Sir, if parametriums are involved, then indeed it doesn't seem to be involved. So for ATP,
but in your case what I'm saying is your patient has atypical hyperendometrium
then we'll
atypical
do radical only.
radical करेगा atypical के लिए
मतलब
no
type
you
one,
would
type
only do a
type one,
simple
type
total abdominal hysterectomy
type one.
Yeah, you would just do a normal TH. Radical करना ही नहीं है, वो कैंसर नहीं है. It is just atypical, dysplastic or disordered endometrium है. For disordered endometrium, you do not do anything radical. You only do a simple hysterectomy. Okay, fine. What if your patient would have had simultaneously menopausal symptoms, or what if you would have had vagina which showed atrophic changes? How would you manage that?
Sir, we can give topical estrogen for atrophic vagina.
Okay, topical estrogen मतलब कैसे स्किन पे देगा कि वजाना में?
नहीं, vagina पे topic.
Okay, good. What else?
Topical lubricants can be given.
Okay, topical lubricants can be given. What if? What about the other screening? What all things would you screen for menopause in menopause for that female?
If BRCA1 and
ब्रेका वन करेगा screen? अरे कुछ भी क्या? I am asking about menopause. What all would you screen in menopause?
Sir, we will for menopause. Sir, you are asking for menopausal symptoms, right?
Yeah, for menopausal symptoms.
Yes, for vasomotor symptoms can be there. For example, hot flushes. Then we can do DEXA scan for osteoporosis.
Very
And
good.
for
Okay.
atherosclerosis, and that we can do lipid profile and all that things.
Okay, correct. Fine. Okay then. So for this patient, your modality is going to be fractional curettage, and depending on that, you would decide whether to do hysterectomy or not. What if your patient would have been a 25-year-old female who has atypical endometrium, atypical endometrial hyperplasia?
Sir, we can give Mirena to her then.
Mirena, or would you advise something more along with it? What is the risk of cancer percentage?
Sir, up to 30% risk is there.
Yeah, up to 20% risk is there. So you would want to advise her to conceive immediately, and after she's done with conception and after she has delivered, you would want to immediately do a hysterectomy. Until then, you can keep her on progesterone support until she conceives, but you would ask her to immediately start the plans for conception because that is eventually going to progress to cancer, endometrial cancer. Okay. If your patient turns out to have endometrial carcinoma on fractional curettage, what is the likely type of endometrial cancer that she'll have, and what is the name of that cancer?
Sir, adenocarcinoma, type 1.
Yes, it is going to be adenocarcinoma. About what type of adenocarcinoma?
Type 1, type 1.
Yeah, type 1 adenocarcinoma, and the patient is obese. What is the name of that special name of that cancer?
Cancer, corpus cancer syndrome. In that,
Yes, corpus cancer syndrome. Correct.
hypertension, obesity, and diabetes is there.
Very good. So in a patient with metabolic syndrome, whenever she gets endometrial hyperplasia and endometrial cancer, you would call it corpus cancer syndrome. Correct. Okay, then next case. Next case is it's a 25-year-old female married since 2 years. She has come to you with something coming out per vaginally. She has no other complaints. Her LMP is normal. She is a nulli gravida, and she has 3 to 4 day cycles, regular, moderate. She has third-degree uterine prolapse. She has cervical elongation, no cystocele, no rectocele. Her bilateral fornices are free. Uterus is of normal size. How do you proceed?
So basically, it is a case of the uterine prolapse with cervical elongation. So in this case, basically for surgical management, basically the support of the uterus is the uterosacral ligament, which is divided into two parts. So the upper part supports the uterus, and the lower part supports the cervix. So if there is a cervical elongation present, then for this we need to do the surgery of Fothergill's repair, basically, in which we will do the
Is it Fothergill's repair, or is there a better name for it?
Manchester Fothergill's repair, basically. And there is one modification that is chirurgical modification present for that surgery, in which we basically advance the uterosacral ligaments, and we have to also suspect for the connective tissue disorder if woman is presenting at such a young age, which can be Marfan, areolar downloads, or myotonic dystrophy, spina bifida, etc. Things to be suspected.
Yes, absolutely. That's a good answer. What if there, in the same history, if the cervical elongation would have been absent and only a third-degree uterine prolapse would have been seen, what would you do?
In this, there is no, sir, no conservative as well as medical management. So we will proceed with surgical management, and basically we will go with sling surgeries. So there
Okay,
are.
what are the sling surgeries that you know of? Yeah, tell me.
Yes, there is Purandari sling, in which from anteriorly we take a rectus, we make a sling from the rectus sheath, and we attach to it a rectus sheath, and from on isthmus of the cervix we attach that, so it prevents the prolapse. So that is the Purandari sling surgery. And another surgery is Shirodkar surgery, in which with Marcelin tape we take posteriorly to the anterior longitudinal ligaments from the isthmus of the cervix and provide support to the uterus. And in Purandari sling, we also do uterosacral ligaments plication, means round ligament plication.
Okay, why do you do round ligament plication in a patient with Purandara cervicopexy?
So basically, if we do Purandari surgery, then the uterus will become retroverted, and this can cause more infertility in the females in future. So, and it will also cause tear in the tissue which is present behind the uterus, basically. So for avoiding that, we will plicate the round ligament also, so that the uterus will remain the antiverted.
Okay, which tissue exactly posteriorly would be torn?
Endocervical fascia, sir.
Yes, what is the name of that endocervical fascia that is present posteriorly?
Rectovaginal fascia.
Yeah, very close. Denon-Willis fascia.
Denon-Willis fascia.
Yeah, correct. Okay. What is Khanna sling surgery?
From the we also take from anteriorly only, and take it to the anterior superior iliac spines.
Okay, correct. And what is Virkut's composite sling?
Yes, sir.
What is Virkut surgery?
Basically in Shirodkar surgery, there was a problem that the slings which we take posteriorly can compress the sigmoid column and cause intestinal obstruction, and they can also cause compression of the genitofemoral nerve. So to prevent this problem, we can on the left side. So to prevent this problem, we can do on right side we can do posteriorly similar to Shirodkar, and on left side we can go anteriorly and do similar to Purandari. And this composite surgery is known as Virkut surgery.
Very good. So it's a combination of your Purandari and Shirodkar sling surgery. That's a good answer. Okay, coming back to Manchester Fothergill repair, could you tell me what is the Sturm stitch?
In basically on we when we create a posterior in Manchester for the gill surgery, we basically do cervical amputation, and we create a vaginal flap of the vaginal mucosa. So to create a mucosa for the after amputating the cervix, we make a from the apex of the that vagina we take a suture, and they from inside of the cervix we take it outside, and then वापस then we take it down, and then again suture.
Okay, correct answer. And what is the Fothergill stitch?
Sir, in Fothergill surgery, stitch is basically for the anterior vaginal wall, anterior side. In that, we take a suture from the from skin beside the vagina to the uterosacral ligament from inside out. Then cervix from there to we take to cervix from outside in. Then again from cervix to outside from inside out, and then again on uterosacral ligament, and then again from the skin of vagina, and then suture it off.
Correct. So basically, you are reattaching your uterosacral ligaments back onto the cervix, which you had resected earlier for the amputation. That is all that is for the gill stitch. Okay, correct answer. What is that one thing that you do along with Fothergill surgery during the procedure? One extra procedure that you do
Sir,
inside the uterus.
we placate the uterosacral ligaments and took them.
No. Something inside the uterus. Something inside the uterus.
Sir, we do prior dilatation and curettage for Fothergill surgery before further.
Why?
Sir, because after surgery, if there is hemorrhage, and if we keep endometrium, if and the female menstruates, then we will not know if it is from the hemorrhage or from the menstrual blood.
Correct. So to differentiate between secondary hemorrhage due to loosening of the ligatures versus menstrual bleeding, to avoid that, we would be always giving these patients endometrial sampling. A lot of people say for doing endometrial sampling, we do it. It is not for endometrial sampling. It is actually just to remove the endometrium, because why would you otherwise do endometrial sampling randomly in a 25-year-old female? Okay, that's a good answer. So can these patients deliver vaginally in future?
Cervical stenosis, there is chance of cervical stenosis in this patient, so it will be difficult to deliver vaginally.
Okay, so there is a loss of cervical fibers, smooth muscle fibers, which is why they are not going to be able to dilate. So they will undergo cervical dystocia during labor, very similar to trachelectomy that we spoke of earlier. Hence, these patients will require a cesarean section in future. Okay, great answer. Fine. So that's a good answer. So young prolapse, that is what all you will be doing. Sling surgeries and Manchester Fothergill repair. In this patient, because there is cervical elongation, you will be only amputing the cervix. What is the normal cervical length, by the way?
2.5 centimeters, sir.
Very good. 2.5 to 3 centimeters. So anything that is more than 3 centimeters is going to be excess, and that is going to be resected. Correct. Okay. Next case. It's a 25-year-old female married since 4 years, nulli gravida, anxious to conceive, history of regular intercourse, 3 to 4 months, cycles at 2 to 3 months interval, moderate flow, painless. She is UPT negative. Her BMI is 27. She has hirsutism. There is no signs of glucocorticoid excess. There is no thyroid swelling, no galacturia. The per abdominal examination is normal. So is her PS and PV examination. What's your diagnosis and how would you manage?
Sorry, basically it is a case of polycystic ovarian syndrome.
Okay, correct.
So in this case,
Why does PCOS occur? Why does polycystic ovarian syndrome occur?
Sorry, basically in that there is genetic predisposition for the increased androgen production from the ovaries and adrenals, due to which there is increased androgen levels, which cause hirsutism and all the hyperandrogenic conditions, and due to increased androgen levels, which are folliculotoxic, which prevent anovulation, which prevent ovulation, which cause anovulation, which results in oligomenorrhea and amenorrhea, and anovulation results in infertility. So that is the one cause. Then there is also insulin resistance due to the serine phosphorylation of the insulin receptors. So due to insulin resistance, there is cell hyperplasia. They becomes more responsive to LH, and there is increased androgen production. So which also causes increased androgen levels and dyslipidemia and all that, all things.
Then lastly, there is a loss of pulsatility, means there is increased pulsatility of GnRH secretion, which results in LH secretion, which causes theca cell hyperplasia, and more LH levels are present throughout the cycle. So there will be no ovulation, as there is no LH, sir. So which can also result in infertility.
Correct answer. That's a great answer. Simply putting it, in our patient, because she's obese, obesity means more of peripheral fat. So whenever there is more of peripheral fat, this female is going to have excessive estrogen because peripheral fat will contain aromatase. Aromatase is going to convert all the testosterone, excessive testosterone in the body to excessive estrogen. Where did this testosterone come from? I'll come to that later. So whenever the estrogen is increasing in the body, your high estrogen will ensure that there is no LH surge. There is only high amount of LH because estrogen has a positive feedback mechanism on LH. Now, whenever there is a positive feedback mechanism of LH, there is going to be a continually high level of LH that is going to be secreted in the body, and the surge is going to not occur. So whenever there is an absence of surge, there is not going to be any ovulation, which is why there is going to be an ovulation. But that LH is ensuring that there are multiple follicles that are created, but none of them are rupturing. So all of these enlarged follicles are accumulating like a necklace all over the ovaries, which is what gives the ovary a polycystic appearance. Now, whenever there is this polycystic appearance, there is also hyperthecosis, basically thickening of the theca of the ovaries and the follicles. This theca is going to, remember, your LH is the substitute for ICSS, that is interstitial cell stimulating hormone that is secreted in men. So this LH is going to stimulate your adrenals as well as your theca cells to secrete more of androgens. So your ovaries are going to secrete more of testosterone, whereas your adrenals are going to secrete more of DHEA. Now these two androgens are going to go to that peripheral fat and then get converted to excessive estrogen. And this is a vicious cycle that is all occurring because of that peripheral fat. That is why your PCOS occurs. So now that I've spoken about PCOS, could you tell me what is the Rotterdam criteria for diagnosis?
So basically, Rotterdam's criteria contains three units basically. So first is the anovulatory cycles, then hyperaldosteronism and androgenism. Sorry, and the third one is the USG criteria, in which we see basically 2 to 9 follicles like in necklace fashion, and the volume of ovary should be
2 to 9 follicles. It is 2 to 9 mm follicles.
More than 12 number of follicles, and for volume of each follicle should be greater than equal to 10 cc. Then upon hyperandrogenism,
not each follicle, volume should be volume of each ovary. Either ovary has to be more than 10 cc.
And out of this,
each follicle has to be between the size of 2 to 9 mm, and each ovarian volume has to be more than 10 ml. Either of the ovaries, not both of them, has to be more than 10 cc or 10 ml. That is how you describe it. You mentioned 2 to 9 ml. No, 2 to 9 millimeters of follicular size, and the ovarian volume has to be more than 10 ml. And more than 25 follicles in either of the ovaries, that is going to be diagnostic of polycystic ovarian disease or polycystic ovarian syndrome. Any two of the three criteria have to be fulfilled. So now that this patient also has hirsutism, the hirsutism is because of the excessive androgens that we mentioned are being secreted by the adrenals and by the ovaries. So how would you manage this patient now? She has infertility, she has hirsutism, and she also has acne. How would you manage it?
For hirsutism we can use oral contraceptive pills.
Which generation?
Third and fourth generation.
Okay. And apart from that, third and fourth generation, preferably the fourth generation. Why fourth generation? What is the difference between first and fourth generation?
Because it is anti-androgen.
Okay, and what is first generation?
First generation is basically norethindrone. Second is levonorgestrel. Means that they are androgenic, and androgenicity increases up to third generation, second generation, and then they are less androgenic. Androgenicity decreases means from first to third, and fourth one is
anti-androgenicity increases at the fourth. Okay, so fourth generation is going to be given. Okay, so for hirsutism, fourth generation. Anything more specific that you can do for hirsutism?
We can give drugs or laser therapy.
Okay.
Other drugs such
as
flutamide, cifroterone, flutamide. Sir, basically the celebration of Ganpati Visarjan going on. We are not hearing. We are not able to hear you.
Okay, fine. Are you able to hear me now?
Yes, sir. Yes. Finasteride.
Okay, so I'm asking. Yeah, continue. What are the other drugs for hirsutism?
finasteride we can give. Then we can give flutamide.
Okay, correct. Any other drug? Spironolactone? Hello?
Yes, sir.
Yeah, spironolactone.
Yes, it is an anti-androgenic basically. So for fourth generation OC pills, that's
Correct. So even that is one drug that you can give. Apart from that, you can also do the manual things. Manual things like shaving, waxing, electrolysis, or ornithine carboxylase का e-fluornithine जो drug आता है, that can also be used for removing the hair. But the primary modality of management, what is it going to be? What is going to be the primary thing that you advise to her?
so first weight reduction will be the first priority.
Very good. So to reduce the peripheral fat, weight reduction is very important. Apart from that, what else? Insulin resistance के लिए.
Dietary modifications will be there.
Okay, what else?
Sir, metformin can be given for insulin resistance.
Okay, correct. What else? Anything else that you would want to give? Because she is also wanting to conceive.
We can give clomiphene citrate for conceiving.
Is it clomiphene citrate? Is it the drug of choice for ovulation induction?
Letrozole is the drug of choice basically because
Yes, letrozole is the drug of choice. Why is letrozole the drug of choice instead of clomiphene citrate?
because basically clomiphene citrate acts centrally and also it acts on means blocks the estrogen receptors in the vagina, which will cause on endometrium. Means so basically it blocks estrogen receptors on the pituitary gland and pituitary gland senses it as decreased estrogen. So which results in increased LH and increased FSH levels. So increased LH and FSH levels will cause hyperovulation, but it acts as an antagonist of estrogen receptor on the endometrium, which will cause endometrial thinning and implantation will not occur. So chances of fertilization are higher because of multi-ovulation, but of pregnancy are lesser because of endometrium is not getting formed.
Okay, correct. Partially correct actually, because your clomiphene has very few receptors. It is in fact a selective estrogen receptor modulator. So your selectivity is restricted only to the hypothalamus. It has very little action on your endometrium. But the first part that you mentioned, hyperovulation, hyperstimulation, is going to be the reason why it will lead to multiple pregnancies. And hence, letrozole is preferred, which won't let this happen. It's an aromatase inhibitor. Okay. In your case, ovulation induction is going to be required and you would be giving it. Anything else that you would be advising to these women with PCOS? Any other drugs that you give for regularization of cycles and all?
OCPs can be given for regularization of cycles.
Okay, correct. So basically, your entire therapy is going to be on the basis of ovulation induction for conception. And apart from that, for your hirsutism, you're going to be giving various drugs. But you have to remember one thing. The moment you start giving ovulation induction, you cannot be simultaneously treating hirsutism because that will lead to feminization of the fetus. Remember that your hirsutism treating drugs are all the drugs that will make you feminine. So if it's a male fetus that the female conceives, then it can lead to feminine changes in her, which is why you have to prevent or you have to stop these drugs, if these hirsutism drugs, if you're going to go ahead with ovulation induction, or you can treat hirsutism first and then start the ovulation induction procedure. So that is it. This is a diagnosis of PCOS. Okay, last case for the day. It's a 16-year-old female who is brought by her anxious mother for absence of menses. She is of tall stature. Her breast development is of Tanner stage 3. Pubic and axillary hair are absent. Her local examination shows non-tender swelling of 2 into 3 centimeters in the inguinal region. There's a blind vaginal pouch. Her ovaries and uterus are not seen. Her karyotype is XY. What's the diagnosis and how do you manage?
So basically, it is a case of, sir, androgen insensitivity syndrome.
Very good.
So
how do you manage it?
So basically, in this case, as there is no, there will be primary amenorrhea, and there will be means genitalia will be means blind vaginal pouch is given. So for basically the testosterone produced by the gonads will get converted into estrogen and will result in the breast development, and there will be Tanner stage 1 and 2 of pubic hairs and axillary hairs. So for managing, we have to give progesterone. We have to do vaginoplasty before marriage.
हाँ बराबर बोल रहा है, तू कंटिन्यू कर. हेलो, am I audible?
Yes, sir. Yes, sir. The disturbance was there on the back, so that's why.
Okay, yeah. So continue your answer. So before marriage, you would
Uh,
want to do a vaginoplasty. Okay. So now the point here is that this is a genotypic male. But unfortunately or fortunately, whatever I would call it, she has been brought up as a female. So now at the age of 16 or 17 years of age, you cannot be telling her parents that she now has to start living as a male because all her life she has been tendered to as a female. So you would want to continue her with you have to ensure that you have to continue her life as a female. Now, what are the crucial things that a female needs to have in her to be looking like a female? First of all, it is going to be her bodily features, which includes her hair. Now, given that she has complete testosterone absence or basically androgen insensitivity, she is not going to have body hair, but her scalp hair are going to be good enough like a female. So you don't need to worry much about that. The part that you need to worry about is going to be your breast. Her breast development is only Tanner stage 3. You need to develop them more. So you would be giving this female estrogen. Remember, someone has mentioned that you would be giving her lifelong OC pills. No, I do not want to give her OC pills. There is no need for giving her progesterone. Why? Because she does not have a uterus. सो उसको प्रोजेस्ट्रॉन देने का कोई फायदा नहीं है. इंस्टेड वो प्रोजेस्ट्रॉन से उसको ब्रेस्ट का कैंसर का रिस्क बढ़ेगा. सो ओनली एस्ट्रोजन, वो भी ओनली फॉर द डेवलपमेंट ऑफ द ब्रेस्ट हैज टू बी गिवन. इफ दैट इज नॉट पॉसिबल, then you can even add an implant, a breast implant, a silicone implant, so that she looks more feminine. Apart from that, you
but
can do, she has a blind vaginal pouch, you can do a vaginoplasty for her. You were mentioning about gonadoplasty. Why would you, gonadectomy. Why would you be doing a gonadectomy? What is the cancer that is most common in these patients?
sir, most common is gonadoblastoma, and most common malignant is D-Germany.
Very good. Excellent answer. So gonadoblastoma is very common and hence you would want to do an gonadectomy. Okay. What if instead of all this, the karyotype would have been XX and there would have been a swelling, a red, bluish red swelling in the vaginal column and she would have had her uterus and ovaries present. What about that? What would your diagnosis be?
Transverse vaginal septum or imperforate hymen can be there.
Very good. How do you manage them?
Sir, for transfer means imperforate hymen, no, sir?
Yeah, for both of them, transverse vaginal septum and imperforate hymen.
Sir, first of all, we will do we can do physical examination and per speculum and inspection basically to look if hymen is tense and bulging, then it is more likely imperforate hymen. If there is suprapubic bulge, will also be present in imperforate hymen as well as transverse vaginal septum. But the bulging of the hymen will be present in imperforate hymen only. So we have to differentiate that on the basis of clinical examination. Then we can go for a MRI to look for the other abnormalities as well as thickness of the if transverse vaginal septum is present.
Okay, how do you manage it? How do you treat it? Is there
For,
any difference between treating them both?
yes, sir. We have to remove the septum in transverse vaginal septum, and in hymen we have to do cruciate incisions. We have to give only.
Very good. And in a transverse vaginal septum, after you have resected the septum, is there anything more that you have to do that you don't do in your imperforate hymen?
Sir, we have to prevent. I think we should prevent the approximation of the means.
Very good. So you'll be putting in a vaginal dilator after the procedure in a transverse vaginal septum so that it doesn't adhere back. There are no adhesions that will lead to a closure of your vaginal vault again. So that is the mere difference. The cruciate incision is going to be enough for hymen because hymen is a mucosal, thickened mucosal layer, whereas a transverse vaginal septum is a complete layer, just like your thick muscular layer, muscular and epithelial layer that is present that you have to resect off completely. Okay. What is the most common complications that these patients end up having 10 years down the line?
For endometriosis.
Endometriosis. Why? Because of the retrograde menstruation.
Sampson's theory.
Okay, perfect. Perfect. So that's a good presentation. You answered really well. And of course, again, you finished it within your stipulated period. So thank you so much, Darshan. Thank you so much, Mohit. And with that, we come to an end of our GynoScope series, the 13 sessions. Darshan, so we are really thank you for your participation and all other three teams. Everyone, you all did a great job. So we'll be announcing the results tomorrow, but thank you so much. That will mark the end of GynoScope. If there is anyone from the organizing team that would like to speak on this, I would love them to take over. And this is Dr. Aditya would be signing off for the last time from GynoScope. I do not know if I'll be there back again next year for this session, but I hope that we continue this annual thing, a free of cost annual thing, as we have stood by that. till the last session. So thank you so much, everyone. It's been amazing. I loved having y'all, and y'all were great. They were great presenters, and everything was really good. The SIMSOC team, they did really well. The things that y'all as attendees have not seen, the backroom work that they have done, brilliant. Be it Harini for conducting and being the one who has managed all the academic part. She is just a first year MBBS student who has done this. So excellent job, Harini. Apart from that, we have several other people, Shivani and Porus, the executive members. They have literally orchestrated the event completely well, very well done. And apart from that, Prachi, Kusumita, Tanisha, Shreya, Ananya, everyone, all of these people have done a great job. So kudos, and you all can be mightily proud of having conducted such a massive event at such short notice and without any monetary thing attached to it. So thank you so much. The winner is going to get a cash prize of 5,000 rupees from the team tomorrow, and we'll be announcing the winner tomorrow. So thank you so much, team, and thank you so much, attendees. Organizing team, if you would want to say something, the stage is all yours. The online platform is all yours.
What an enriching and closely contested finale this has been. On behalf of SIMSOG and Dr. Aditya Nimbkar's ObGy Masterclass, I extend my heartfelt appreciation to all our finalists for their outstanding performances. We are deeply grateful to Dr. Aditya Nimbkar for his constant mentorship and guidance, and to all of you for your enthusiastic participation and support in making GynoScope such a success. Before we close, a gentle reminder, please do not forget to fill out our post-event form. The link has been shared in the chat box, and your inputs will help in making our future initiatives even better. Thank you once again, and we look forward to seeing you at our upcoming academic initiatives. Thank you.